Yes. Done.
Uh, Good afternoon, everyone. Welcome all to our monthly webinar from Palghar Academy of Pediatrics. We are back again after a short break. And since our Prime Minister has also said to work from home, so it is better that we conduct the webinars from home instead of traveling in such 45 degrees Celsius temperature and getting ill. So, welcome you all. And since this time we have a lot of good speakers, we'll directly start with the webinar. And our first speaker is Dr. Aditi Dandavate. Welcome, Aditi. Aditi
Thank you,
is
ma'am.
a pediatrician working at R.N. Cooper Hospital. She is an assistant professor there. She has 6 years of experience in undergraduate and postgraduate medical education. She has completed her post graduation in pediatrics from Sion Hospital. She also works at Synergy as a pediatrician, and she has previously worked at Joshi Children's Hospital in Virar. She is a firm believer that preventive health is the key to building a strong future. So, welcome Aditi, and kindly share your screen for the interesting case.
Thank you, ma'am. Thank you for the introduction. So, just sharing my screen over here. Am I visible, audible?
Yeah.
Yes, your screen is
Okay.
also visible full screen. Yeah, you can
Okay, ma'am.
start.
So this was case which came to our Cooper Hospital presented by me. So this was actually the presentation is not that rare. It is a long-standing fever, fever more than 3 weeks with hepatosplenomegaly. I'm sure all of us आपण सगळ्यांनीच असे केसेस बघितले असतील. Especially people ज्यांचा fever on off होत राहतो or there it is persistent for a long time. So moment we see fever with hepatosplenomegaly, immediately our mind goes to a certain set of diagnosis. So let's see some demographic details for this child, Kundan. He is 5 years old and he had come with his parents. Father is a cook, mother is a housewife. The living facilities seem okay. There is no common toilet or kitchen. They have their own kitchen with tap water and indoor toilet. But this native from Bihar recently moved to Mumbai. Actually, he started developing fever there. That is why the father brought him here. Otherwise, the most of the cooks they are living in communal living with other cooks and they don't have families around. But this child was brought here because he was very sick. So let's see the chief complaints. 1 month of fever with intermittent touching baseline, but with paracetamol and high grade documented high grade spikes 102, 103. So, and apart from that, recent onset abdominal pain, which was well localized to the right side. It was dull and not radiating, not a sharp pain. And it was no variation with food or any aggravating relieving factor. Now, this is accompanied with a abdominal distension also. So, along with this, the child was gradually having a progressively increasing abdominal distension. And on the day of admission, he had reduced oral intake. So, long-standing fever and with reduced oral intake. So, what are we thinking? Anybody can chip in. Hello?
Yeah. So
Yeah,
any
yeah.
fever of unknown origin, day 5 with no localizing sign, typhoid fever, one would think of malaria.
Yes. And this upper abdominal distension, we would like to think maybe
In
of
liver,
the right, pain in the
liver
liver, probably
pathology,
yes, hepatomegaly,
galley.
upper abdominal distension on the right side. So this is our question: ki 5 month old with 1 month of fever from a zone which is endemic for many tropical illnesses.
Kala Azar.
So, so that let's jump to our what was the course of this patient. So he had high grade fever. Then he went to an OPD, treated for malaria, then treated for with doxy. There was no effect. Then, because of this pain and right upper abdominal distension, he was like because of the pressure effect and all, maybe his appetite was reduced even more. So he was taken to a private hospital in SBS hospital in Andheri West, and from there, because of clinical worsening, the child was referred to us. When he came, he had some respiratory embarrassment because of the large liver. Hepatosplenomegaly was there. And key feature, they had done some investigations and they had referred saying INR is deranged, so child is getting sicker, so you please take him. He came to us. So we asked few negative histories like a deranged INR, so we asked for bleeding, encephalopathy. There was no history of that. Child was very active and completely oriented. There was no rash, joint swelling, lymphadenopathy, any other autoimmune marker. No history of TB, which is the most important question in our country. And there was no history of jaundice or pale stools. To give an idea about the excretory function, it seemed to be maintained. So epidemiological context we have that he's a native of Bihar, which is endemic for Kala Azar, and he belongs to a socio-economic class wherein the infective pathologies are very high related to overcrowding and poor food and water hygiene. And malaria endemic zones, there was no travel, but now I think entire country should be considered malaria endemic because of the construction. So nothing relevant in that. So again, past history in the SBS hospital where he was admitted, he has received some antibiotics, Piptas and metronidazole. For some reason, Lasix had been given, I'm not sure why, and the child was referred over here. There was no previous history. Developmental and birth history was uneventful. Family history, father is a cook, mother is a housewife. There is no consanguinity, no familial liver illness, no contact with TB or jaundice, and then immunized for age as per the national schedule. So on admission, he was febrile. He had tachycardia, tachypnea, BP was maintained, and saturation was also maintained. Now, general examination, he had pallor and he had icterus also. So now the right upper quadrant pain and distension, he has one more supporting feature, that is he is having icterus. There is no other significant general examination finding. Now, anthropometry, if you see, his height is okay for 5 years, 106, it is maintained. Weight is 16 kgs on, apparently it looks maintained, but if you see the MUAC is low. So maybe that enlarged liver is also contributing to this weight. So there is a component of acute malnutrition. Chronic nahi hai because the height is maintained. So there is some failure to thrive over here. Most probably just acute. In that 1 month, he has dropped some weight but gained in the form of that liver. So let's see the systemic findings. This very prominent feature, liver span of 14 centimeters, almost palpable till the right iliac fossa, and it was quite firm with well demarcated borders and just a mild spleen, not at all like what you would expect for such a large liver. It was very, very small, almost negligible. So other systems were fine. But he did have a grade 2 systolic murmur, which we attributed to the anemia because he did not seem to have any deviation of the apex and the heart sounds were otherwise okay. No signs of meningism or encephalopathy. He was oriented well. So this was our differential, like what Jayashree madam, Anjali madam, Vaibhavi madam, both of them mentioned. Like Kala Azar definitely should be considered over here. Malaria and liver with high grade fever. Never forget viral hepatitis. Dengue, again, not much of a, but we still put it in the differential that like high grade fever is there, and TB, never like very pertinent in our country. And these three were our other diagnosis like malignancy because high grade fever with pallor and with such a huge liver and some splenomegaly. So we thought, is it a lymphoblastic leukemia? Enteric fever because of the socioeconomic class and the other features. And we just thought of autoimmune versus SLE, that because many a times they do come with high grade fever and this hepatitis component. So at this stage we were very confused about how to go about because such a broad list of differentials, but definitely the infective pathology we had at least one, two, three, four, five, and six of these are infective. So we were very certain that infection should be ruled out. Although Amdekar sir always says the longer the fever is, the less chances it is that it is infective. But definitely in our country, we should think of infective. So this was supportive for us. The native the hepatosplenomegaly, prolonged fever, malaria because tropical setting is there, hepatitis because of the large liver and deranged INR icterus, dengue because I will come to the investigations eventually, but this child did have thrombocytopenia as well. And there is a weight loss, there is a chronic fever with
But dengue after
hepatosplenomegaly.
7 days, Aditi, would be unusual. So
It is very unusual. Yeah,
Yeah.
not at all in our first few diagnoses, just there to complete the list. And malignancy because of cell line depression, organomegaly with fever, enteric. There seems to be some problem with the. So we did some investigations, and this Kala Azar antibody was done. It's an indirect Coombs test and antibody test. There was peripheral smear we did, and we planned a bone marrow aspirate because that is the most sensitive test. Then malaria, we did a PSMP and rapid antigen. Serology for hepatitis, all negative. Dengue, of course, negative. For tuberculosis, we did our regular workup. Gastric aspirate, chest X-ray, everything was fine. Malignancy study, our peripheral smear did not show any blasts. And we planned a bone marrow aspiration for this as well. And for enteric fever also, I think there is some text missing. Okay. Because of the stepwise fever, we thought it may be there. So Vidal blood culture at this stage, again, it's been 4 weeks. So stool culture would be the investigation of choice, which was sent, but again, it did not contribute, and we sent a Vidal as well. So this was our CBC chart. So when he first came to us on 4th, his HB was low, TLC was low, platelets were also low. All the 3 cell lines were affected. And along with this, they had a microcytic hypochromic picture without any malarial parasite or without any lymphoblasts in the peripheral smear. So that doesn't mean that the marrow will not have blasts. So just that they were not there in the peripheral smear. Now eventually the HB remained somewhat same. There was no drop. There was no rise as well, but the counts seemed to recover to some extent, and the platelets as well. They also recovered. So, what treatment was given, we'll come to that. But this was the progression. The CRP was 105, which is again supportive for infection, inflammation, both. So, and the ESR was 28. So, we found some other investigations which we have sent are, of course, a liver profile because the liver is so large. We found that SGOT, PT both were elevated, OT more than PT, but both are elevated. The GGTP is also elevated. The ALP is fine, and the bilirubin is also fine. So the icterus was probably transient, mild, not very significant. But the total protein and albumin both are low. Especially the albumin is quite low, along with a deranged INR and APTT both. So this was a bit alarming because in like PT-INR, as we know, is a measure of acute liver failure, and this being deranged means that there is some derangement of liver function, and albumin being deranged means that the pathology is chronic. So is it that we are dealing with fever, the infection with chronic liver disease with some component of early acute liver failure because the CNS has not been affected yet? So that was our question. And etiologically wise, the extensive list of investigations we have done did not contribute anything to our investigations. So now we started thinking that we should do a biopsy. But which biopsy? Should we do a bone marrow biopsy to find hematological malignancies or infection? Or should we do a liver biopsy to rule out chronic liver disease? Or what should we do? So then we did some more baseline investigations. The liver echo texture was homogeneous. In infective hepatitis, we would expect it to be heterogeneous, but this was relatively maintained echo texture. But you can see in the X-ray, the last rib and the liver is almost 6 to 7 centimeters beyond the last rib. It's very, very big. And compared to that, you can barely see the spleen on the X-ray. And the abdomen also doesn't have much of this, maybe little bit of gaseous distension, but nothing else. So then we continued with the hepatic drip with IV antibiotics, and he did not respond. So then we found a very surprising and I would say a little bit underwhelming diagnosis, because at this stage we were constantly what further workup to send, HLH workup, or should we send ferritin, D-dimer, what do we send? And then this investigation came back. So the first Vidal we had was from the previous hospital, and then this was our report, which came on day 3 of admission, 1:1280. And so we had our diagnosis over here. Of course, not yet confirmed, but still, if you see in this stage, our Vidal was just 1:80. And I think in Mumbai, nobody would treat or consider this 1:80 because it is
Yes.
all of us are exposed to salmonella in our while eating at
Yes.
restaurants, street food, water.
Yes.
So
Yes.
1:80 holds nearly no importance. But the rising titers are important. Vidal is many of the infectious disease specialists are not very fond of the investigation because people don't understand. They try and treat it in isolation, but the rising titers does have a very important role, and that should be documented before treating. Like nobody would advise you to treat a 1:80, especially with a atypical presentation. If you have a child who is clearly fitting in the typhoid clinical spectrum, then you may treat 1:80 also and get document rising titers. But here, this child had a lot of atypical features like thrombocytopenia, low counts, and low HB, murmur, large liver. All these are not very commonly seen in enteric. Usually, you would see diarrhea, soft, like tender abdomen or tender mild hepatomegaly, mild splenomegaly. But anyway, so
Aditi,
considering,
over how many days did the this Vidal rise?
so the first one was done like 2 days before the child came to us. So this was done after the 5th day. That is, the first Vidal was done at the previous hospital. And I'm so sorry, we sent it over here at the time of admission. So maybe 2 to 3 days in between, not 5 days, 2 to 3 days. The report came on the 5th day. So at this point, we had stopped all the other medications, anti-malarial, doxy, everything was stopped, and we escalated him to meropenem plus azithromycin, which is the given drug of choice in XDR typhoid because he had been on Piptas for a long time, almost 6 days, and there was no defervescence. So considering XDR typhoid, we stepped him up to carbapenem and macrolide, and he did show respond to that. Along with that, the liver span also started regressing, the INR normalized, and the CRP also, if you remember this chart, it came to almost 6.6 just in 6 to 7 days. Sorry, 7 to 8 days. And I think that was all he needed. All the symptoms got better, all the labs also got better. The coagulopathy improved, the counts recovered, platelets recovered. And then when he was treated for around 7 to 10 days, afebrile, the oral intake was restored. Then we planned a discharge. Now, this was our therapy. Meropenem at 20 mg per kg per dose, 8 hourly. He had no renal derangement, so we did not need to adjust for that. And macrolide, remember, macrolide, the dose is higher for enteric fever. It is not 10 mg per kg as for mycoplasma or atypical infections. Azithromycin is 20 mg per kg per day for up to 7 days. This is from IAP textbook of pediatric infectious disease. And of course, supportive care, which goes without saying, and micronutrient supplementation because this child had been sick for almost a month. And so we rehabilitated him in nutritional ways also. Apart from that, iron was given, calcium was given, multivitamins, OPD review, and we advised immunization for typhoid. And most importantly, we told please screen the father because he is a cook. We don't know how many families he must be infecting if he is somehow reached a chronic carrier state. So he is a cook. So we sent a stool culture for the father. We advised him to go see a surgeon, get a USG done to see polylithiasis, cholecystitis changes in the gallbladder. In such cases, sometimes even bile aspirates may be sent for culture. So all this was done. And yeah, this is our map. We are highly endemic for typhoid. If you can see the darkest color on the map, It is just sad because we should be moving from infective to non-infective diseases now. That epidemiological transition should be happening, but our population, overcrowding, poverty, all these problems are very tied in together with these illnesses. So anyway, this was the three important contributing factors to us putting a picture. So Salmonella typhi with transient hepatic dysfunction and coagulopathy. This was the diagnosis that we gave him because the coagulopathy did resolve on its own. We had given only one dose of vitamin K and 3 days of vitamin K, and with that the hepatic enzymes also recovered and the coagulopathy also recovered. We even monitored it later, sent it repeatedly, but it stayed normal. It did not go back to the T-range state. So, urban poor setting with overcrowding, no typhoid vaccine in the universal immunization program. That is a very important fallacy and a gap that we have in our immunization schedule. Even after being so highly endemic, we don't have typhoid vaccine in the schedule. And all these contributing factors which are quite contributory for enteric fever. Just the size of the liver and the severity of the hepatomegaly and the low albumin threw us off slightly. We started thinking that it may be a chronic liver disease. So asked about consanguinity, thought about Wilson's disease, sent the child for KF ring. Nothing came positive. And except for this one lab investigation, which gave us the diagnosis. And sadly, we didn't get a blood culture, but he had already received 3 days of antibiotics before he came to us. And then we had also given antibiotics, so we couldn't get a positive culture. So the workup mattered because we should be thinking of other things also, especially in the setting of pancytopenia and Bihar origin and like this hepatic dysfunction coagulopathy with low albumin. So if we had not gotten a diagnosis, we should have done a bone marrow to rule out uh, at least a malignancy, LD bodies, and also bone marrow culture has great positive predictive value in enteric fever. If you are not able to isolate the organism in blood culture, bone marrow culture is very, very helpful. And we have done that for a few patients in Sion. So we should be doing a bone marrow aspiration for such patients. Thankfully, we got a diagnosis without needing it, but if we had not, then we should have been doing a bone marrow culture. Takeaways, we should be always considering just fever does not mean infection. Everyone of us knows this, and but we should consider infections before everything else because they have such a large disease burden. So keep other causes also in mind, but think about infection always. Then Vidal interpretation we have covered that you should never interpret single values. You should always think about rising titer. Send it again after 48 hours and see the response to the antibiotics. See if the titers are falling or rising. And of course, blood cultures are, it depends a lot. So it, even an ideal blood culture scenario, it should be properly scrubbed with 2% chlorhexidine. A sufficient sample of 4 ml should be taken for a pediatric sample, and the transport medium should be good enough, preferably a bactec bottle. All of these variables are very difficult to trace. Like I know my juniors are also always overworked. They fill 1 ml sample, ho gaya, color aa gaya, bhej diya. So whenever like blood cultures, if it is important, please make sure that it is sent in a very ideal way. And MDR and XDR typhoid are very much there in India now. So what does MDR typhoid mean and what does XDR mean? So MDR is resistant to the first line of antibiotics, that is ampicillin, trimethoprim sulfomethoxazole or Septran, and chloramphenicol. So nowadays nobody uses any of these drugs for typhoid anyway. So what is relevant to us is XDR typhoid, and the problem is this is resistant to the two most commonly used drugs, that is third generation cephalosporins, which is the mainstay of our treatment, and fluoroquinolones. So these two will not be very helpful over here. So one may argue that this child was directly started on Piptas. Maybe he was sensitive to ciprofloxacin, but somehow we did not end up going to ciprofloxacin, we upgraded him to meropenem and azithromycin, which is the drug of choice for XDR. Now, it originally originated in the Sindh outbreak in Pakistan, but now it is there everywhere. And maybe we see some change in the drug sensitivity patterns over time, but right now our mainstay of treatment is still third generation cephalosporins or fluoroquinolones, though we in this patient, because he had a long standing fever, we should rule out TB before using a fluoroquinolone, because fluoroquinolones are part of second line AKT. So, yeah, we escalated to meropenem and azithromycin. And enteric hepatitis is reversible. It is a transient phenomenon, but it doesn't mean that you don't need treatment. Should be treating it with supportive care and vitamin K and hepatic drip and supportive care and monitoring. And yeah, this is from one of my UG students. So complications of typhoid, like we know, typhoid ulcers, perforation, hepatomegaly, and if antibiotic therapy is not started, then death direct. But before we go to that stage, we should think about enteric shock, which is again not mentioned over here. But because Salmonella is an endotoxin, your initial antibiotic therapy will cause an increase in the fever, increase in the symptoms, may cause an obturated stage because there is sudden rise of endotoxin. Endotoxin is the dead body of the bacteria. If you give antibiotics, the dead bodies are going to increase, they are going to cause a flare. So in such cases, you may use a small dose of dexamethasone to tide over the crisis. And then when the patient has stabilized hemodynamically, you may stop the steroid. In this patient, of course, we had not used because we were thinking of malignancy also. So we never give any steroid to any patient with suspected malignancy. So maybe if we had done a bone marrow and ruled out malignancy, then maybe we could have given. So, but yes, perforation and typhoid ulcers and are important complications. So what should we take back to our ward? One is always anchor in the denominator. Like you should consider the endemicity of every patient when you make a diagnosis. Kala Azar must be ruled out actively in this patient. I think one of the only things against Kala Azar was he didn't have a large spleen. They usually have a very large spleen, even in the photographs that are mentioned. Second is never interpret Vidal in isolation, never treat it in isolation. It has tremendous cross reactivity with all sorts of tests, but if your clinical picture is fitting and you can document rising titers, then you are very much justified in treating that. Monitor the liver enzymes and INR to ensure that recovery is happening. And if you are having a non-responder, you should escalate to a carbapenem and azithromycin and consider XDR typhoid because it is very much there in the population, and this will prevent complications. And every patient should be immunized for typhoid. Actually, it is very, very sad that we don't have a typhoid vaccine in our schedule, and I hope that changes soon. But till then, the typhoid conjugate vaccine, even a single dose is very, very helpful. I know many, like most of the pediatricians give a one dose at 9 months, 6 to 9 months, and then a booster dose before the child starts school. But even if one dose is given, it is still has a good amount of protection, and always something is better than nothing. So every child who has come with clinical suspicion of enteric, culture positive, Vidal positive, please advise them for two things. One is hygiene measures and second is typhoid vaccine. If you can convince the mother, and it will give lifelong protection to the child. So these two things. And with that, I conclude my talk. So thank you very much for patient listening.
Nice presentation,
Aditi.
Aditi, thank you very much for a very nice presentation.
Thank you,
Two
sir.
questions for you.
Yes, sir.
First is azithromycin before or meropenem before? After ceftriaxone, how many days you will wait for the ceftriaxone to act, and when you think of adding azithromycin, and when you think of adding meropenem?
So
Because
ceftriaxone, sorry, sir, continue. Only the natural defervescence expected is at least 5 days.
Hmm.
So 96 to 120 hours is mentioned in the textbooks also. But defervescence च्या बरोबर you should see other improvement also with ceftriaxone. The child who is maybe prostrated, obturated should, like, the activity should improve. Maybe little oral intake should improve. With all of this, if the fever spacing is improving, the intensity is reducing, I will not upgrade. I will be okay for if the child is getting fever for 5 days. So, but if none of that is happening and the child is still worsening, then maybe we would wait 3 to 4 days around some.
So if there is a ceftriaxone sensitive blood
हाँ,
culture report
हाँ,
and the child is having fever for 5 to 7 days, the second sensitive antibiotic is azithromycin
हाँ,
and carbapenem, means meropenem or anything. You would like to use meropenem or you would like to use azithromycin?
we will like
So
to use
when will you use
azithromycin.
meropenem? My question
Meropenem,
is that.
हाँ, so long standing fever आहे, child is not improving in the other areas. And if the appetite is low, then, and if he is having features of shock, then I would like to upgrade to meropenem. Otherwise, oral acceptance आहे, तर azithromycin may be used.
So आम्ही जे काही बघतो, आम्ही जे काही करतो त्याप्रमाणे if the child is very toxic and you have already diagnosed as culture positive, then only we usually म्हणजे use meropenem, but very rarely. आणि if the child is ceftriaxone resistant, then in that case we usually use meropenem, but not otherwise. So sensitivity आणि resistance त्याचे बघणं गरजेचं आहे. Second thing you talked about steroids. So how early you advise to use steroids? And when you advise to use steroids?
So steroids, the role is actually in the initial 2 to 3 days when your antibiotics are going to kill massive number of bacteria and cause a cytokine storm. And that time, if the patient is facing hemodynamic instability, high grade fever spikes, needing inotropes वगैरे, then steroids will help. Their role is more in the initial days more than anything, as mentioned in
It is very
the
dangerous to use initially in 1 to 2 days time when the child is so toxic that if he requires inotropes and everything, then really steroid will means I will be very skeptical about using the steroid at that particular junction of time. After 5-7 days, if the child is clinically active and if the fever is still there and I know that the ceftriaxone sensitivity is there and I'm waiting for that fever defervescence to occur, then for a day or two, if you use steroid and let the fever go down, in that case, usually what we use for 1 or 2 days of steroid, let the patient feel better and go home, and then we continue with the IV antibiotics. That is what we were means.
I can share the screen actually. Nelson माझं उघडच आहे. त्याच्यात पण त्यांनी म्हटलंय की in addition to microbials, additional treatment with dexamethasone is 3 mg per kg initial dose followed by 1 mg every 6 hours for the 48 hours is recommended for severely ill patients with shock, obtundation, stupor or coma. Only under strict supervision, of course, because they mask the abdominal complications. But the dose is definitely in, like the role is definitely in the initial stage when the child is having that septicemia because of sudden increase
if there is
in
a
the
septic shock,
endotoxin
then
load.
only.
Yes.
Okay, thank you. Learned new things.
Thank you, sir.
Can I add
Thank
something?
you.
Can I add something?
Yes, sir.
Hi, excellent presentation.
Thank you, sir.
I'm a bit out of depth here, but I have seen a couple of typhoid ulcers over the last 10 years in practice. Only 2, I think, and then 2 or 3 typhoid ileus. I think these are the only situations where steroids should be absolutely like not used at all. Because if
Yes,
you
sir.
got typhoid ileus or you got impending perforation or a child who's got bilious vomiting. So I've seen about 4 or 5, 2 of them perforated. We had to do surgery. 3 of them managed conservatively. And I've seen my wife, who's an adult intensivist, use steroids for typhoid because sometimes they come with bad SIRS kind of response and
Yes,
then you
sir.
have to use steroids. The other thing that I noted very well from your presentation, which I've also seen my wife do, is that in 48 hours, repeat the Vidal if you got a PUO with more abdominal complaints. Then just repeat the Vidal, because that sometimes picks up, like in your case exactly, you may pick up. And sometimes even repeating a blood culture or a stool culture repeat also picks up, because we've picked up resistance by just repeating the blood culture, and we've picked up, I don't really know why that happens, or whether under some suppression the typhoid bugs are not being detected, and then eventually maybe the antibiotic cover sort of starts being very less effective, and then it starts being detected in blood again, something like that. I don't know, but that's when we have picked up resistance by repeating the uh, cultures,
Yes, sir.
and then immediately swap to meropenem, and that has worked.
Yes, sir. Yes.
Yeah. Wonderful presentation, Aditi. The only thing I'm
Ma'am, one
surprised
question. One question.
what I'm surprised is that after 3 weeks of fever, the Vidal done at your center was 1 in 80. And immediately after 2 days, it became 1 in 1,200. That is a bit surprising. So that was something that I'm wondering. And I don't know what is the protocol at your center, but we, for any PU of whatever duration, we do start with ceftriaxone if we have an infective pathology with typhoid as a this. And I haven't seen resistance to ceftriaxone in many, many, many years. They have all responded
Recently,
to ceftriaxone.
recently there are some resistant cases of ceftriaxone proven on culture with our local labs also, and they have responded to azithromycin. Some have responded to meropenem, but then we need to give them some 5 to 7 days of time actually for the meropenem, means for the ceftriaxone to have resistance. Means I have referred so many patients to Dr. Tanu Singhal, and then ultimately she says that, okay, give now oral azithromycin and discharge the child. So it's like that. So there is definitely resistance to ceftriaxone, which is coming up in a big way, but we need to wait and watch. And still, ceftriaxone is a
Wonderful.
it's a golden drug for enteric fever.
Yes, sir.
Don't buzz
Yes.
away from that. So
His
we will
first
not
line
take a wrong
remains.
message of not continuing ceftriaxone. Meropenem is not the drug of choice. Ceftriaxone is still the drug of choice, and it will remain
Yes,
the
sir.
drug of choice. Never to use ofloxacillin, never to use ciprofloxacillin in enteric fever, and try to withhold meropenem for a critical infection.
Yes, sir. Mainstay of treatment is still
Absolutely.
third generation cephalosporin.
Absolutely.
This is just one of the rare cases where,
Absolutely.
In a very sick
and
child.
ma'am, to answer your question, actually, he had been started on piperacillin tazobactam from outside. So when he came, we just decided to continue that. We usually, we don't step up to piptaz immediately. Our first line before we can diagnose is usually just amoxiclav, then ceftriaxone, then in enteric, of course, amoxiclav, no role, but usually ceftriaxone before anything. Yes.
What is a hepatic drip? Want to know. If you
Hepatic
mentioned.
drip is usually we use a higher concentration of glucose, so with a lower sodium load, and that is just during the period of hepatitis if to prevent the child from going in hypoglycemia. We sometimes add calcium gluconate as well. So rather than D5, we try to make the concentration somewhere around D7 or D8. With the help of D10 and RL, we make the drip. So the
Okay.
child has little higher concentration of glucose. That is all, nothing else. And it has a multivitamin infusion also with it.
Okay. Thank you.
Chat box, there is a question. Is there any role of chloramphenicol in resistant cases when other things have failed?
In pediatrics, never used, not not considered a very safe drug. And maybe in the many years ago, it was first line drug for typhoid, but extensive resistance was there. Maybe because it has not been used in long time, the resistance may be lesser, but the safety profile of the drug is not very good. So I have never used it.
Chloramphenicol is a good drug. Only thing is there are better drugs available with lesser side effects. So might as well use that rather than get your fingers burnt with chloramphenicol. We have seen bad results of chloramphenicol. Might as well I'll remain away from chloramphenicol. Aplastic anemia is worst side effect of chloramphenicol, and we have seen that. So it is better
Yes, sir.
to avoid chloramphenicol.
And one more question, whether oral azithromycin in 20 mg per kg or should we give IV? IV or
We
oral?
we have always used oral, ma'am. The textbooks also mention oral. IV azithromycin, IV doxycycline we have used, but azithromycin never used IV.
Single
It
dose
needs a
oral
lot of
on empty
uh,
stomach.
yes.
Okay. Yeah. Thank you, Aditi. It was a very nice discussion on typhoid.
Thank
So
you, ma'am.
our next speaker is Dr. Kant Shah. He is a pediatric surgeon and working at present at Nanavati Hospital. And sir's topic is children who present late for surgery, cases and lessons learned. Over to you, sir. Yeah. Sir, you are mute.
Yeah, I'm very sorry you asked me for some information about me. Couldn't give you. I totally forgot
So
when
you
you
can
introduced
tell
Dr.
yourself now.
No, I don't need to. When you
Yes,
introduced
sir,
Dr.
we know.
Aditya, I
Yeah.
realized it's okay. No, I don't really need to introduce myself. I'm just a pediatric surgeon, and I'm going to talk about. Can you see my screen?
Yeah,
Yes,
make
sir.
it screen. Yeah, please make it full screen.
I tried to. Can you see the full screen now?
No?
Yes,
Yeah,
sir.
now. Yeah.
Okay. So over the past few years of practice, I'm going to highlight 3 short cases and then how and what lessons we have learned. The first thing is that the late presenting children are not really anybody's fault. It's more of a systemic problem, and that problem is slightly increasing because nowadays there are, as we saw in the earlier discussion also, there are so many things to consider for a referring generalist practitioner. There are too many specialists involved. All of us keep giving too many guidelines, and for everything now there is a guideline. There is a guideline for even how the constipation should be graded, and there's a guideline for ABC, everything. And what that means is there's just too much information overload, and it's hard to keep up with everything. So, and then patients are very impatient about a lot of things, and sometimes we don't all get enough time to consider the patient as a whole or in the longer term. And this is true for me also. If I have to refer to you for something, then I may think twice, or I may just say, we'll see later, or things like that. So what really matters in today's day and age, I think, is just remembering the red flags or the important points about most of the diseases. And then that's usually what would entail an early referral. It could be just a phone call. It doesn't have to be a formal referral also. And that usually helps everybody. The 3 cases that I'm going to discuss are newborn jaundice, undescended testis, and urinary infections. So this is the case of a newborn who looked perfectly well, and there was a short window which was quietly spent. So if you look at the history, the baby had jaundice soon after birth, and he was he was otherwise well. But on day 15, there was some persistent of jaundice, and some blood tests were done, which showed a slightly high bili. A direct was 2.2. So the baby was thriving, so wait and watch approach was taken. By day 30, the baby was still jaundiced. Repeat bloods were done where the bilirubin had slightly increased. And of course, because of this, an ultrasound was also done because the direct component was also high, which was reported as normal. Now, if you look on review of the ultrasounds and looking at the actual images, it was found that the gallbladder looked empty, but then on asking the parents, the baby had just been fed before the ultrasound scan. So the gallbladder can look empty, and that's what was written in the report, that post feeding status of gallbladder. So because of the conjugated hyperbilirubinemia, a HIDA scan was ordered, and after obviously 5 days of phenobarbital priming, which showed that there was a decreased excretion of bile into the intestine. The baby was still well and still gaining weight. So a referral was made to the pediatric gastroenterologist, who did all the blood tests and figured out that the ALP and GGT were raised. The liver enzymes were mildly raised and torch screen was normal. They undertook a repeat ultrasound gallbladder to rule out surgical causes. There it was picked up that the gallbladder was small, and even at this stage, no pale stools were recorded. So by day 50, which is not a lot in a baby's general lifespan, is about a month and 20 days, the child was referred to me as a surgeon, where I asked for a fasting ultrasound. So a fasting ultrasound showed a non-distended gallbladder, and then this was clearly to me a case of biliary atresia unless proven otherwise. So we undertook to do intraoperative cholangiogram and a Kasai procedure. But before that, I had to tell the parents that their liver transplant may also be required in the future. And at 1 month and 20 days, this is a little bit of a worry for any parent to say that we are going to do a very major surgery. And then even after this surgery, they may still require a liver transplant. So there are a few things here which I would like to highlight. One is, we all know the pathway that the bile, how it's produced and gets into the bile ducts, into the gallbladder, common bile duct, and into the intestine. The only step that a HIDA scan actually sees conclusively is that the bile was in the intestine. Sorry. Yeah. And the HIDA scan really asks only one question: did the bile reach the intestine? It doesn't say if there is a blockage, where it is, why it is, etc. Now, if you look at it, if the bile is reaching the intestine, the stools will have color. So if you have a stool color chart, you really don't need a HIDA scan. So if the bile is reaching the gut and the stools are colored, the question is already answered. So you don't really need a HIDA scan. HIDA scan is almost completely obsolete in today's day and age, at least for any kind of biliary atresia, choledochal cyst, or any kind of surgical problems, which are sort of surgical emergencies in the first 1 or 2 months of life. The well-looking baby is also a trap, because this is what everybody wants. We all want a well-looking baby, a baby who's healthy. And a baby who's healthy, our natural instinct is to buy time and see what happens. But we have to understand that biliary atresia is a surgical emergency. And these children, unless their liver is cirrhotic to a certain limit, they will actually keep on feeding well, gaining weight, and keep looking very healthy, even up to 3 months of age. And by the time they come back with ascites and all that, the liver damage is very silent and progressive, and often it is irreversible in these children. So this is another very important thing to remember. The third thing to remember from this case is that a pale stool is not always present in biliary atresia. Pale stool only happens when the bile is definitely stopped reaching the gut. In early biliary atresia, pale stools may or may not be there, or they may be partly there. So if you give a proper stool color chart to the mother and say, what all stool colors have you seen? Instead of asking what is the color of stool. If you ask what is the color of stool, she'll say it's yellow. But if you actually give her a chart and say which all yellows have you seen? And some of those faintly pigmented yellows, which you and I will also probably call yellow, are actually biliary atresia, where once in a while the child actually has got pale stools. So having a stool color chart is very important. But again, one has to remember that pale stools is not always present in a child with biliary atresia. Again, that only comes with late stage disease. So we really don't want to wait for pale stools. The biggest and the easiest thing to do for any child with conjugated jaundice beyond 2 weeks of age is to do a fasting ultrasound. In a fasting state, the gallbladder should be well distended. If you have any other terminology like not well distended, small, acontractile, blah, blah, blah. You will see all kinds of things being written on an ultrasound report. That is usually a red flag. If you see on a 3 or 4 hour fasting ultrasound, a well distended gallbladder, that usually means that you can wait. And if you don't see a proper well distended gallbladder on a fasting ultrasound at 2 weeks of conjugated jaundice, 2 weeks of age with conjugated jaundice, that should be the earliest and immediate red flag referral for a workup for biliary atresia. Here is the chart, and why we bring up the issue of liver transplant in these children is because if the biliary atresia is operated less than 45 days, and now the world is looking towards less than 35 days. So if you operate on a biliary atresia, do a Kasai procedure less than 35 to 45 days, then there is a 80% chance that the child will survive for a very long time with their native liver. Now, a Kasai procedure, if you ask me, has got more than 90% failure rate in the long term. Immediately, most children will do well and we will prolong their liver transplant. 30% will need liver transplant in the first 2 years. 30% will need transplant in the first 10 years. And 30% may be able to avoid transplant for more than 10 years. But only 10% will survive with native liver disease, native liver in the very long term. This is large data across the biggest centers in the world. That is the fact of biliary atresia. But if you want to reduce or eliminate liver transplant, then the Kasai has to be done at a much younger age. Initially, the entire impetus was to do it less than 90 days, then came 60 days, and now the whole world is looking for 35 to 40 days. So that's the very short window, because we're looking at 15 to 20 days when you first pick up conjugated hyperbilirubinemia in a newborn, which we call persistent jaundice. From 15-20 days, you have a very short window to get to surgery. And so any investigation which prolongs this, like in a healthy baby, a torch screen is usually not useful. In a healthy baby with colored stools, the HIDA scan is absolutely not useful. Only very specialized centers should be doing liver biopsy, and there are hardly any in Bombay. So pre-operative liver biopsy is again not very indicated. A quick fasting ultrasound at 2 to 3 weeks age when there is conjugated hyperbilirubinemia, immediate referral for an intraoperative cholangiogram and a Kasai procedure will hopefully help us avoid all the liver transplants that are happening. Even to date, one of the largest subsets of children having liver transplant is biliary atresia. And you and I can work together to really reduce this completely. And the best way to do it is early referral at 2 to 3 weeks with a fasting ultrasound. The second silent crisis, I would say, is undescended testes. Now, general practitioners used to refer cases at 6 years, 7 years for undescended testes, even 10 years I have seen, 12 years. Of course, with the pediatricians now looking after most of the children, hopefully in the entire country, the referrals have come much earlier. But there is still a big subset of children who come to us beyond 12 months of age. Oops, sorry. What happens with every delay in the month is that we may actually lose the testis. Even after surgery, there may be incomplete descent. So we may not be able to bring it down where we actually wanted, right at the bottom of the scrotum. There is a much higher atrophy risk because the more we have to pull it, the more the blood supply will get stretched, the more chances of it becoming atrophic. And now data is coming that beyond 2 years, if you're doing a undescended testis, even for a palpable testis, you probably need to add laparoscopy. Now, this paper has only come last year, but at our center, we've been using this for almost now 4 to 5 years, where Dr. Pradeep and I have been reviewing our cases. And we have found that in a 2 or a 3-year-old child, anybody slightly older, in a 2 or a 3-year-old child, or even anybody slightly older than that, it is very difficult to bring down even a palpable testis right at the bottom of the scrotum where it should be. Because what happens is, as the child grows, even if you bring it down now, eventually some of them may go up again. And we don't want that happening. So we want to avoid the bigger operation of adding a laparoscopy. And so the ideal age, as you are all aware, that when a testis is going to descend in the first 3 to 4 months. Beyond that, it doesn't descend. Beyond that, these genetic changes start in the testis. So by 6 months, all children with undescended testis should undergo surgery, maximum by 12 months, and at least they should be referred by 6 months. If there is still a progressive history of descent, well documented, we may wait till 12 months. But if there is no progressive descent documented clearly, then by 6 months, children should undergo surgery for undescended testis. This is a lesson that we are learning slowly now, that the older children, the testes do go up sometimes, and we don't want any of this. We don't want to lose a single testis when we are operating, basically. The third is a short case as well. Sometimes urinary infections are not so simple. And this is again a child who at 4 years of age underwent surgery for a spinal lesion in a very big hospital. And after that, there was no documented follow-up, although the parents kept going to the neurosurgeons. He started having recurrent UTIs, ended up going to a pediatric surgeon who checked for reflux. He had reflux and did an anti-reflux surgery. Now, in a child with a spinal lesion, most likely the condition is going to be a neurogenic bladder and not a primary vesiculate reflux. So as you are aware, reflux is primary or secondary. Primary means it's there from birth, where the valves of the uretary vesicle junctions are not working well. And that's why they reflux. And most of them actually don't need surgery today. Less than 10% need surgery. Whereas a child who was normal, did not have any problems, undergoes some spine surgery or has a occult spinal lesion, when they get reflux, this is called a secondary reflux. Or they had posterior urethral valves and they have reflux. Or they were operated for anorectal malformation, now they have reflux. All these children have a bladder problem and not a reflux problem. They have neurogenic bladder, they have high pressure bladders, and doing anti-reflux surgery is not safe for the kidney also and not safe for the bladder also. Unfortunately, this child underwent an anti-reflux surgery. Things were quiet for a bit. But then again, he got admitted with one big infection at 12 years of age. And there they find out that he was in complete renal failure. So imagine this 4-year-old kid was completely normal, had a spinal lesion, must have had some mild problems with that, not a major problem. He lived for 4 years without a problem. He undergoes 2 surgeries in 2 very major corporate hospitals, and then ends up in renal failure with a creatinine of 4 at the age of 12 years. This is a failure to society, because now with that kind of a picture, this child's kidneys are completely fired, and he's now in permanent catheter with the right treatment, some basic anticholinergics, this and that. His pressures have come down, and he's managed to his creatinine has managed to stabilize at 1.4. But at 13 or 14 years of age, a creatinine of 1.4 is not looking very good in the long term. He's probably going to be a candidate for for renal transplant eventually. As we all know, kidney transplants also don't last forever. They last for 15, max 20 years, even in children. Best case scenario. So what life are we committing to these children? So, and now he needs to undergo very major surgery for bladder augmentation, which we're planning in the next 1 or 2 weeks. We'll augment his bladder to lower the pressures. We'll need to have permanent CIC catheterization. All of this he would have needed anyway. He would have needed the bladder augmentation. He would have needed the permanent catheterization and all that, but from the belly button, not from below. But at least we could have saved his kidneys, because eventually whatever you're doing, we are doing for the kidneys. So any urinary tract infection may not be simple. Assess urology if there is any involvement of spine, anorectal malformation, previous history of urological surgery, then these are absolute red flags that these children should not be taken as simple reflux. Any single UTI in such children should not be taken lightly. Is a harbinger and a red flag for upper tract damage eventually because of a bad bladder. So we have to manage the bladder to save the kidneys in these children. And absolutely contraindicated to have undergo any kind of anti-reflux surgery in all of these children, whether it is PU valves or neurogenic bladder or anorectal malformation. See, in anorectal malformation also we do the surgery from behind where we completely open the sphincter. So some of these children undergo neurogenic bladder secondary because of the surgery. So these children also, if you're managing these children, anorectal malformations who've thrived well, they're okay from their potty problems. But if they come to you with UTI, that's an absolute red flag. That probably that child has a neurogenic bladder. They need to be treated urgently and immediately. All children definitely, we know that they have a neurogenic bladder, like undergoing spine surgery, should undergo CIC, which is clinical intermittent catheterization from day one. I've got a child from Nalasopara where the mother has been, I did the meningomyelocele repair at Dr. Indu Khosla's place probably about 8 years back or 7 years back. And the mother was taught CIC. The baby was just born 4 days, I think 3-4 days old. And the mother was taught CIC by me daily for the first few days. And since then, that child's mother is doing CIC. And her kidneys are completely normal. Completely normal. She's got creatinine of 0.4. Of course, they have not gone ahead and accepted to do the major surgery, and she's living with CIC. The mother is okay, the child is okay. She's now 7-8 years old, and they are not agreeing for the major surgery, which I think is okay if they are managing. But because the mother and child were taught CIC from day, from the first week of life, that child is a completely protected bladder. So even children from slightly remote areas, also I have got in JJ, we used to get children from very remote areas also, and we managed to teach CIC. It works very well. You manage the bladder properly, you can protect the kidneys. So most of the monitoring for such children is very non-invasive, simple bladder diaries and ultrasounds, even a uroflowmetry once in a while. And very rarely do they need urodynamics, which we have, but we don't really use it so often. So in conclusion, no one can know everything really. So refer early and remember these simple red flags. In each of these children, the diagnosis was reachable and damage was preventable. What was missing was not knowledge. It was an earlier phone call or an earlier conversation. And I think this is something that we really need to work towards, all of us, for all specialties. If I need to refer to you, then I need to know what are the red flags and vice versa. Just as a by the by, I'm developing a small tool here. I think it has recorded the conversation when I recorded this when we were having the presentation. So we've built a small tool where, and I've not launched it yet, but you will be able to, like, if you want to give propanolol for hemangioma, you can put a child's weight. You can decide whether you want to give it twice a day, 3 times a day. You want to give it as a dilute solution, as a concentrated solution. It will tell you how to give exactly, blah, blah. Same thing, if you want to do bladder diary, you want to give oxybutynin, you want to refer for incontinence, stool chart for constipation, stool chart for biliary atresia. So I've just about started building this about a week and a half back. So it will take some time to perfect it, but all the red flags, which is the normal stool color, all this. And I would really appreciate if you all contribute to help me what you need from our side to build this into a good tool. So this will be free for all. It will be downloadable. It can be used as an app or it can be used online. And thank you very much for this lovely opportunity. So nice to see all of you again. Thank you. Thank you.
Well done, Pam.
This is an app that will be available for mobile.
Yeah. It's a very, very simple system. It's on your mobile. There's a link. You can click it, or on an iPhone or Android, you can save it as an app also.
Okay.
And whenever you're connected to internet, it updates itself. So suppose I put some 2 new tools tomorrow, then it'll update itself. And if there are no new tools, it'll just be as it is. So you can use it offline also on your phone, or if you're connected to internet, you can use it online also. It's
Fantastic.
very, very simple and very easy to use.
And there are 2 questions from my side on your talk, which was
Yes,
a
sir.
great talk.
Thank
So
you, sir.
if there is an undescended testis who gets operated at 6 months and found to be slightly lesser in size and atrophic,
Yes,
whom
sir.
to be blamed? The pediatrician, the nature, or the surgeon, or the patient comes and says that if there was an undescended testis and it should have been operated earlier, and at 6 months we usually tell them that till the age of 6 months, they get descended and you can operate after the age of 6 months. And at 6 months, he gets operated and there is a atrophic testis.
So you are saying it was palpable and a good size earlier, and by 6 months it has become small?
Yeah.
Is that what you're
No,
saying?
no, there was an undescended testis. We usually said that there is testis cannot be felt now, but usually the testis usually descend. It's a protocol that you
Yeah,
operate after
we
6 months.
Correct.
Yeah. So after 6 months, you start searching for sonography or MRI or whatever, Palana,
Correct.
Dikna, whatever the
Correct.
thing.
Correct.
And then the patient gets operated and there was a atrophic testis. And then they said that if there was an undescended testis, you should have told us earlier that you should get operated earlier and we would have operated earlier.
Okay, so an undescended testis which is atrophic at 6 months is most likely
Can
it
be a
has happened.
congenital.
It
Can be a
has
congenital.
happened. It has happened developmentally. It has not happened because of waiting. Because waiting means we are talking about waiting years, not months. So waiting for 6 months will not make a testis atrophic unless the only situation really when that can happen is there was a undescended testis which has undergone torsion in the groin. So you felt a big testis and it underwent torsion in the groin. And that is the only situation where it was there and it has vanished at 6 months. Otherwise, it was probably not there from birth. There are three main reasons why testes vanish at birth and not afterwards. What I'm talking about is, so I'll come to what I'm talking about. So the testis vanishes mostly because the blood supply so when we do laparoscopy for these children where it's not palpable, we see that the blood vessels and the vas have just abruptly stopped. It means that there has been an intra-abdominal torsion of the testis when it was being developed. And this is a very clear-cut case that it has happened developmentally. So there is no question of blaming anybody at all. Second, you see the vas and vessels are complete, entering into the canal. And then there is no testis in the canal. And this is again usually considered as a perinatal torsion.
Yeah.
Perinatal torsion where the testis has descended into the groin. We don't know of what size, but now it is not there. Again, nobody to blame. The only rare situation where the testis was felt and now it is not there. So when we see an undescended testis below 6 months, we tell them, especially a very mobile one in the groin, we tell them that see, ideal time to wait is till 6 months. If there is associated hernia with it, or if it is very mobile, we even operate at 3 months sometimes. And while waiting, please make sure that at any point, if there is any sudden pain or blackening, then immediately go to a surgeon and get it repaired because that could be a torsion. So this is what you're supposed to say before 6 months.
So this is where the testes are palpable in the inguinal region or in the course of the testis when it descends down.
Correct.
If the testes are not palpable at all,
Yeah.
In the left side or right side, whatever.
Correct.
And how many months you will wait for that thing to
6 months,
get
6 months.
investigated? 6 months. Right?
6 months direct laparoscopy. By that age also, if you can't
So
feel it,
that is what we are
laparoscopy.
saying. 6 months, if the thing is there, then the pediatric surgeon can't blame any of the pediatricians that the testis
No.
you should have operated earlier.
No, not at all.
Because the protocol is
first
6
of
months,
all,
right?
No. See, protocol is 6 months, but in our country, we should never blame each other. Practically speaking, that word should never come out of my mouth. Even if I see a child who has been sent to me at 10 years and they tell me that the pediatrician or a GP asked them to wait till the child is older, we should never utter such words to our patients because God only knows what they will make out of it. And in India, slapping a doctor is so easy, blackening their face and putting them on a donkey is so easy. So first of all, that blame game should never ever happen. We can say that, look, what I say generally in such tricky situations where delayed referrals have been happened and what we call protocols are internationally accepted things. There is no, it's not written in stone, but these are internationally accepted guidelines that undescended test is 6 months surgery. So I say that, yeah, 6 months surgery is advisable. Maybe they asked you to wait because maybe they felt that it will come down. Now it has not come down. It is high time that we operate. That is all. And usually I just don't try to get into that conversation at all. That's because blaming each other is really not going to work.
Second, regarding your first case, hyperbilirubinemia, direct jaundice.
Yes, sir.
So, which is earlier, the direct jaundice or the clay color stool?
100% direct jaundice. Direct jaundice has very strict criteria. It has to be, even if it is more than 20% of the total bilirubin, or if it is more than 1 milligram per deciliter, then it's a direct jaundice. So such children at 2 weeks should be investigated by the fasting ultrasound. Pale
So-
stools is not common, sir. And pale stools में ना वो
Pale
बैठ
stools
के
will come after one. Pale stool usually comes after 4 weeks. It doesn't come before that.
there is no timeline, sir. There is no timeline. But if you sit with the parents and you sit with the stool chart, so I have this printed stool charts kept in my this thing. And now I won't with this app, but now until now I have had printed stool charts, and it goes with the file also. If you sit and ask them carefully, okay, which all colors have you seen? If you ask them which is it now, which is it, they will usually say which is it now. But if you ask them which all colors have you seen, then they will often pick up one color. But this is very, very subjective, sir. And this is very, I mean, the mothers are really wrong, but when it happened, how it happened, sometimes some Ajji is looking after it, the kid or whatever. So pale stools is not a criteria. Hydra scan is not a criteria. Any kind of liver disease is not a criteria. The only criteria is conjugated hyperbilirubinemia with a fasting ultrasound, which does not show well distended gallbladder. All of us, if we fast, our gallbladder will become so big that on the ultrasound scan, even if you hold it 2 feet away, you know this is the gallbladder. That's how the gallbladder looks.
I will give you one example in my case. Means I had one patient who came to me on day 2 consecutive week visits at 5 days and 15 days, and there was no hyperbilirubinemia. And after directly he came to me after 4 weeks with bilirubin of 12 with direct of 8. Luckily, that child did not have a biliary atresia. It was just viral hepatitis, and it was just hepatitis, and it went. But then the relative said that you told me to come after 15 days. I have come after 15 days. And now the weight gain was not there, and there was a direct jaundice. So I could not say that this direct jaundice when. So you said that you come after 15 days, I have come after 15 days, and now you are saying that this is serious problem. And which was not there. I had come only for not weight gaining. You gave me the formula. I gave the formula. And now there is a direct jaundice, which was more than 35%, 40%. So that was a question. And there was the pale stools came after that.
Correct.
So 1 or 2 days after that, the pale stools came.
So that's something, sir. Even little bit of bile. Bile is such a strong color that even little bit will color the stools. So it is a very strong pigment. So we should definitely not wait for pale stools. In your case, I think there was no conjugated hyperbilirubinemia. So any child who doesn't have conjugated hyperbilirubinemia can be just asked to come after 15 days. That's perfectly normal. Even biliary atresia can come slightly later. It can come at 30 days, 40 days also. So it is not always congenital. It is not always immediately at that point of time. But 2 things are important. One is serial investigation. So serially, if you investigate, and again, in your case, the child was not gaining weight. This is very unlikely biliary atresia. Biliary atresia children will be very well. Unless 2 things. One, they have biliary atresia with CMV, with family history of biliary atresia. I have one child like that, where they presented at 15 days. But that's super rare. I've only seen like 2, I think, in my entire career. And although documented is 25%, but I've really not seen so much CMV and biliary atresia in our country at least. And the second possibility is not biliary atresia, something else. So that's very rare to have biliary atresia in an unwell child, or not gaining weight child, or not feeding well child. And that's why we miss it. Because we say at 15 days, theek hai, thoda 2.2 conjugated bilirubin is very easy to miss it, because we
There
are
was
like,
no conjugated
not in
bilirubin
your
as
case,
that.
not in your case.
Yeah.
I'm just talking about the typical cases that come to me.
Yeah.
Almost all the cases which come to me at 30, 40, 50, 55 days, all of them have the same story, that there was some conjugated hyperbilirubinemia and the ultrasound was normal. But then we waited, because we are waiting for what basically. The only thing that I want to say is that documented conjugated hyperbilirubinemia with the criteria of more than 1, or more than 20%, at 15 days or maximum by 21 days,
You
with
need to monitor.
should be immediately
Followed.
undergo simple fasting ultrasound. And if that doesn't show a well-distended gallbladder, send it to us. If it shows a well-distended gallbladder, then weekly monitoring or whatever. But not too much, like as you said, 15 days, what you did in your case. Not very long monitoring, because these are children we want to pick up very early, all of these.
So what is misleading in biliary atresia is that the children are growing well, one,
Yes.
and that the jaundice is not very high.
No, and even for me to ask the parents to do the third ultrasound is also very difficult, madam.
Yeah.
Because I don't want you to get into a situation where they think that the first two ultrasounds were not done properly. So what I do is I write them a very long list of things and I said, look, this is a specialist ultrasound which is focusing on the liver. I need little more information. It will help me with the surgery also if it requires surgery, blah, blah, blah. So I have to make some sort of a story to tell them why, because I don't want to get into a situation where I'm blaming somebody. It's not really the point there. And in this app also we'll have forms. So you can download the form for the liver ultrasound, form for the renal ultrasound, form for whatever common things we are doing.
Thank you. Thank you so much.
Kant,
Very nice.
sometimes when you don't see pale stools, they also advise to cut the stool and see the core of the stool.
I have
Sometimes they say bile colors the outside layer, and so you cut and see for the pale stools.
Ma'am, I've not heard of this, but basically what I'm trying to say is that we should not bother about pale stools, is all I'm trying to say.
Okay.
We should really not worry about it. And if we sit with a chart with the parents, I can assure you that mothers will tell you that yes, once in a while they have seen the pale stool. Because if you look at the chart also, you'll also see that the type 1 also, which is severe pale stool, also sometimes doesn't look very pale to our naked eyes. It's just when you see the whole chart and sit with a mother, they will say, हाँ, कभी-कभी ये light yellow भी होता है, but then that light yellow is actually pale stool. It's not acceptable for a child to have any amount of pale stool. That's why the chart is important.
Thank you.
Thank you, Dr. Kansha. It was an
Thank you so much.
excellent talk and a very eye-opening talk also regarding when do we refer patients and how to pick up as early as possible. Okay, so now our next speaker is
It's always
Dr.
nice to interact with Kant. Always.
Thank you,
This
sir.
lasts
Thank you
so
for all
many
the
years.
lovely questions
Yeah.
also, actually.
After ages, we have interacted with you
Yeah,
Yeah,
today.
it's so nice to see all of you. So nice to see all of you.
Good.
So our next
And
speaker
can I
is
just add that I really
yeah.
loved Dr. Aditi's talk. Thank you so much.
Yeah, Aditi was great.
Thank
Hi,
you,
Aditi.
sir.
I think we are
Thank you
using
so
Hi,
the
much,
same
sir.
AI to
Hi.
make our presentation.
That's what I was
Yeah.
going to ask you,
Cat GPT.
which app
No,
we
no,
are
it's Claude.
following
It's
because
Claude.
both
It's
the
Claude,
Claude.
yes,
presentations
Claude.
were literally
Not
similar.
even Gamma.
Not ChatGPT, it's Claude.
Okay.
Yeah, we use
Okay.
I thought it was Gamma.
Yeah. Yesterday
Claude.
only, day before yesterday, we heard a talk on AI in pediatrics, and I was wondering which app you both are using for the presentation.
In fact,
Okay.
this
Yeah.
entire app also I have built on my own using AI.
Super.
Wonderful, sir.
Good.
Very good presentation.
Thank you. Thank you.
Yeah. So
Hi,
our
all
next
of you.
speaker.
I've got OPD, so I'm going to rush. Is it okay?
Yes.
Okay, yes,
Sorry.
Kant.
I'm sorry. Thank you. Thank you. Bye.
Thank you, Kant.
Thank you so much.
Thank you, sir.
Thank you.
Our next speaker is Dr. Shailesh Barot. He is a pediatrician and neonatologist at Ankur Pediatric Multispecialty Hospital, and he is going to talk on update in rabies immunization. Over to you, sir.
I'll share my.
Yeah.
Everybody can see my screen.
It's yes.
Yeah. Please
Yes,
make
sir.
it full screen. Yeah,
Okay.
Yes.
Thank you.
Yes, sir. Yeah.
So,
full screen,
to
sir.
Palghar Academy and
Sir, your screen is visible.
Yeah, thank you. So rabies, the burden is very large and it is increasing over days and days, and our animal lovers are sorry if I'm bothering anyone by saying animal lovers, but then the disease burden is becoming very big. almost 10.4 million animal bites occur in India every year. And this was 2020 ka data. So in another 5-6 years, the number of dogs and the number of bites must have increased a lot. Of that, almost 1,000 rabies death happens in world every year, and out of them, 20,000 alone in India. And 40% of the deaths are in children. So if we are to prevent rabies, then we need to really act. So we are every conference has a rabies lecture nowadays, and we are promoting anti-rabies vaccine and monoclonal antibodies so profoundly that at least none of the doctors should not offer anti-rabies vaccine or monoclonal antibodies to a animal bite. That is the basic funda for this lecture. So how is the rabies transmitted? It is through infected bites, infected rabid animal saliva, through either bite or through licking or by broken or embedded skin. Rarely it happens after surgery, and usually the mammals, which are dogs, cats, monkeys, and other animals, are responsible. Monkeys are definitely more commoner nowadays, has happened, and it is not transmitted through squirrels or turtles or rabbit. And India, bats do not transmit the rabies unlike America.
What about rats? Very often.
Rats never bite and never transmits rabies. It is not a carrier for rabies.
Thank you.
Yeah. So incubation period is usually 1 to 3 months with a range of 6 days and to many more years. Less than 1% case occurs after 6 months of exposure. But usually the incubation period is 7 to 10 days after the exposure. So you need to worry about first 7 to 10 days. And if it is the bite is on head, face, or highly innervated parts like fingers, then the incubation period is slightly shorter. So you need to worry about them more. So the basic funda for post-exposure prophylaxis or vaccination or monoclonal antibodies is the same, that you have to give the injection within 7 to 10 days to reach the antibodies level faster. So we give more number of injection like 0, 3, 7, 14 to make the antibodies level reach faster. And you should not delay the vaccination or monoclonal antibodies to any of the patients. So there are who has suggested 3 categories. Category 1, where you are touching the animal or the animal is licking on your intake skin, then there is definitely no risk of rabies. You do not require anti-rabies prophylaxis, but definitely when you are going near the animal and if you are an animal lover, then you should offer them pre-exposure prophylaxis. But when in a doubt, when you don't know whether the animal has scratched or whether the animal has just licked, then there is a simple spirit test. If there is you apply the spirit, and if there is a irritation, then your skin is abraded and you already become category 2 bite. Then you need to take anti-rabies vaccination, at least post-exposure prophylaxis. So category 2, so this is spirit test is important. It's a good way of saying that it is category 1 or category 2. Category 2 is minor scratches or licks where there is no bleeding from the wound. Only you require local wound care and rabies vaccination, but there is no rabies immunoglobulin or monoclonal antibodies are required. So again, in this post-exposure prophylaxis, 4 or 5 injections, whatever are recommended, you should give. But treating the wound locally is very important. Why? I'll tell you that also. Category 3, where it includes all bites who have bleeding from the wound as well as mucosal exposure and requires local wound, local therapy with rabies immunoglobulin and rabies vaccination. So if any doubt in categories, please let me know. I'll correct it once again. So how to take care of the wound? You have to wash the wound thoroughly under running water for 20 to 30 minutes with soap and water. But it has to be running water. It is not stagnant water, and you have to wash for 20 to 30 minutes. Why? Because it usually clears 60 to 70% of the viral load by just cleaning the wound properly. And when you apply spirit or betadine, you usually take care of the 80% of the viral load. So chances of getting rabies only by cleaning and decontaminating, reducing rabies is very high. You should never apply local irritants like turmeric or lime or soda or something, because it increases the inflammation, it increases the blood supply to that particular wound, and chances of spread of viruses are very high because there are open nerve wounds. Now, third question is whether to suture the wound or not to suture the wound. You should not suture the wound in first 7 days time till your antibodies are raised, means are developed in your body, means after 2 or 3 injections of your rabies vaccine, or you have taken rabies immunoglobulin after the bite. After 7 days only you can suture the wound. If there is too much of bleeding, then you can just take minimum 1 or 2 sutures to approximate the skin and to prevent the bleeding, but you should not suture the wound. After 7 to 10 days, you can do secondary suturing for cosmetic reason. Understood? Okay. Now, tetanus toxoid and antibiotics. If the patient is vaccinated, you need not give tetanus toxoid, but you can definitely give a course of either amoxicillin or amoxiclavulinic acid for 5 to 7 days. Rabies immunoglobulin and monoclonal antibodies. What is the rationale of local infiltration of rabies immunoglobulin or rabies monoclonal antibodies? So when the rabies virus gets transmitted from exposed nerve roots to CNS and leads to rabies, rabies vaccination takes 7 to 10 days to reach protective levels of antibodies that will prevent rabies virus transmission, right? So once the virus gets fixed to the the root, the vaccination will not help the rabies and it will not prevent the rabies. So category 3 bites, usually when the nerve roots are exposed and we have to neutralize the rabies virus in the wound, you have to give either rabies immunoglobulin or monoclonal antibody earlier. So maximum how many days you can give? Up to 7 to 10 days you can give monoclonal antibodies. If the patient has not received vaccination, you can give up to 1 month also. So if RIG or monoclonal antibodies is not given on day 1 in category 3 exposure, local therapy in form of RIG should be given as early as possible along with vaccination. However, if there is no immediate available, one should start the vaccination at least, and local RIG or monoclonal antibodies can be given up to 7 days of exposure. Why till 7 days? Because after 7 days, once the vaccination 2 or 3 doses are given, the antibody level, automatic protective antibody levels automatic rises up to 7 days, and then there is no benefit from your immunoglobulin or monoclonal antibodies. So if the vaccination is not started up to 7 days or 1 month also, then you can use your RIG or monoclonal antibodies up to 1 month also after the exposure. And where you will give, so at the site where the animal bite was there you can give intramuscularly. Okay. Who should receive RIG or rabies monoclonal antibody? All category 3 bites, including mucosal exposure, should receive local therapy with rabies monoclonal antibodies. On re-exposure, it is not required for any category of exposure unless the host is immunocompromised. So if you have received your post exposure prophylaxis, or if you have received your pre-exposure prophylaxis, then you should not take monoclonal antibodies. then only rabies vaccine is sufficient. That will come later on. So for all wild animal exposure like monkeys, etc., one has to give monoclonal antibodies for even class 2 exposure, which I said earlier that all wild animals you should give even in class 2 exposure. So you don't require. Yeah. So if the subject is immunocompromised, you will have to give, even in re-exposure cases, you will have to give monoclonal antibodies. So technique is you have to give with 26 number needle locally from outer to inner till your immunoglobulin or your monoclonal immunoglobulin is oozing from the wound. If the wound is too small, then you have to first calculate the dose, how much is required. That will come to later on. And up to that particular dose only you should give. You should not give more or you should not give less. So if the wound is very small, you can infiltrate the wound, but you should not infiltrate too much so that it leads to compartment syndrome or ischemia or gangrene. But rest of the dose, if it is there, you should not give intramuscularly. Now it has been absolute that the rest of the dose you should throw away, or you should use in some other patient if there are multiple patients, but you should not use, you should not give intramuscularly. But if the wound is very large, if there are multiple bites and you need to infiltrate all the bites, still you have to calculate the dose and you can dilute with normal saline and you can infiltrate the whatever number of. So you should first see the wounds, how many wounds are there. You should calculate how almost 0.5 ml per centimeter is the requirement. So you can calculate your requirement of dose. You can calculate your dose, whatever is there for monoclonal antibodies, and you can dilute accordingly and you can infiltrate the whole wound. If there is a if there is a mucous membrane involvement and you cannot infiltrate, you can infiltrate in the mucous membrane also. But if there is eye involvement or if there is a buccal mucosa involvement, then you can dilute the monoclonal antibodies and you can make them gargle, or you can wash the eye with the monoclonal antibodies. That will definitely decrease the local viral load. Yeah. So there were equine which was available, immunoglobulin, but now it is no longer available. There were human immunoglobulin, rabid immunoglobulin, which were available, but that was becoming too expensive. So now we have almost everybody has now switched over to monoclonal antibodies. There are 2 monoclonal antibodies in market available. We will take the name, which is one is mono, that is Rabishield by Serum Institute of India, which is fully human rabid monoclonal antibodies, and second twin rab by Zydus, which is double rabid monoclonal antibodies, which is combination of 2 different murine rabies monoclonal antibodies. So mono that is single rabies monoclonal antibody binds to single site of rabies virus, whereas double RMAB means rabid monoclonal antibody binds to 2 different contagious sites on the rabies virus. Hardly it makes any difference. Both the monoclonal antibodies act similar and has almost same results. Almost the price of both of them are same. If there is a weight difference, then only sometimes this twin rab is cheaper and sometimes the Rabishield becomes cheaper depending on the size of the wound and the weight of the patient. So whatever is available, it is equally good. Both of them are good. So you can use any one of them, no problem about that. So dose, if you are checking, rabies shield dose is usually 3.3 unit. I am not talking about ERG or HRIG. We are talking directly about only monoclonal antibodies. Rabies shield dose is 3.3 units per kilogram and twin rabies 40 units per kilogram. And it is now almost your rabies monoclonal antibodies has replaced rabies immunoglobulin. So that was immunoglobulins and monoclonal immunoglobulins. Now we talk about vaccine. So rabies vaccine. So there is something called as post-exposure prophylaxis, and there is something called as pre-exposure prophylaxis. There are some people give 4 doses, some people give 5 doses post-exposure, some gives intradermal, some gives intramuscular. So who gives intradermal, who gives intramuscular, who can give intradermal, who can give intramuscular, that we'll talk about. So in India, rabies vaccines are licensed for intramuscular as well as intradermal routes. Intradermal route is usually 0.5 ml irrespective of the vaccine, hence is cost saving compared to intramuscular route. So usually government of India uses intradermal route. And whereas in private practice, one uses intramuscular route because it is simple and easy to give. And definitely there is protection is better than, there is nothing like intradermal protection is better than intramuscular protection. But sometimes intradermal route, who is giving intradermally and whether that has really gone into intradermal or subcute, that we don't know. That's why we prefer intramuscular route, because if patient is paying the full amount, rather we should give the full intramuscular route to that patient. But if there are multiple patients of one particular family, and if they are not affording and they want to take vaccination at your place only, then you can give intradermal route, provided you are very confident about how to give intradermal route. Intramuscular route should never be injected in gluteal region, and if it has been injected in the gluteal region, then you have to consider it as invalid dose, and that dose has to be repeated. That is for 100% sure, means don't ignore that. So what is the prophylaxis? So WHO and USA says, and many other agencies, including our IAP, ACVIP, were saying that there are 4 doses should be given intramuscular on 0, 3, 7, and either 14 or 28. Between 14 and 28, any day you can that patient can take the vaccine. But in public health in India recommends 5 doses given on 0, 3, 7, 14, and 28 days. This is intradermally given. But now recently IAP and ACVIP also is recommended 5 doses. Another schedule is 2 doses at 2 different sites on day 1 and 2 doses, 2 more sites on day 7 and 21. So totally you are giving 6 doses, 2, 2, 2. So almost the exposure, the available doses remain the same. So there is no much, means if the patient wants to go somewhere and wants to take the dose somewhere, then you can use it. But usually 5 doses are more than sufficient. So even in your private post-exposure prophylaxis, please give 5 doses rather than sticking to 4 doses. It has been clear now that you should give 5 doses, and new ACVIP guidelines will come with 5 doses in another 1 year's time. What is the schedule of intradermal post-exposure prophylaxis, site 3 or 4? So WHO recommends ID route giving 2 sites 0.1 ml intradermally on 2 different shoulders on day 0, 3, 7 on back of the interscapular, but 2 sites 0.1 ml. Public health recommends 2 sites 0.1 ml each on 0, 3, 7 and 28 days. So post-exposure, but our Indian government has started giving 5 doses, right? So 2 sites they were giving intradermally 0.1 ml, and the protective level is usually 0.5 international unit per ml. is the protective. So when you consider, if you don't want to take the vaccine later on, you can always test your anti-rabies neutralizing antibodies. And if it is, the titer is more than 0.5, you need not take the vaccine. So pre-exposure prophylaxis, what is the rationale of pre-exposure prophylaxis? So it will prime the subject with vaccine given before the exposure, so that in future, if the patient gets exposed to that, then it requires only 2 doses of vaccine as re-exposure prophylaxis after 3 months of the primary prophylaxis. If within 3 months the bite occurs, then you need not take the re-exposure prophylaxis also. And you need not take immunoglobulin or monoclonal antibodies if you are previously vaccinated with the rabies virus vaccine. What is the schedule? WHO says pre-exposure prophylaxis, 2 doses of vaccine given intramuscular, means 2 sites, intramuscular on day 0 and 7, or 2 sites intradermally, each 0.1 ml on 0 and 7. So either intramuscular 2 doses on 0 and 7, or 2 sites intradermally of 0.1 ml on 0 and 7. But ACVIP and Public Health in India gives 3 doses. So first was WHO internationally. What we give in India is 3 doses, either intramuscular or intradermal, 0.1 ml or 0.5 ml intramuscular on 0, 7 and 21 to 28 days. Anywhere between 21 to 28 days, you can give 3 doses. Who should take? Those who go for morning walk, those who are postmen, delivery boys, laboratory personality, veterinary doctors, pet owners, pet lovers, pet trainers should always take pre-exposure prophylaxis. What is re-exposure prophylaxis? So post-exposure prophylaxis is valid for 3 months from the last injection, beyond which, if there is exposure again, one has to give re-exposure prophylaxis, which consists of 2 doses given intramuscular on day 0 and 3, or 1 site intradermal 0.1 ml on day 0 and 3, or 4 sites 0.1 ml on day 0 itself. So if the patient does not want to come again, if he wants to go somewhere outside, then you can give 4 different sites 1 inch apart of 0.1 ml on day 0 itself, 4 sites. Then it is almost as good as taken a full re-exposure prophylaxis. Or you can give 2 doses, either intramuscular 0 and 3, or intradermal single dose 0.1 ml 0 and 3. And there is no need of giving local rabies monoclonal antibodies for re-exposure prophylaxis unless the host is immunocompromised. Okay.
What about annual boosters or 5-year boosters?
It is not recommended, ma'am. It is not recommended because it has been proved that it can increase your pre-exposure prophylaxis when you give 0 and 3 doses, or 3 doses when you give pre-exposure prophylaxis. The antibodies last for almost 18, 20, 25, 30 years. And when you are having post-exposure, means there is an animal bite after 3 months, you already take 2 vaccines. So again, you have got a booster of so it acts like a booster, and your antibody titer increases. So there is no need of annual booster for the rabies.
Thank you.
So if the child has taken initial vaccination at public health, like intradermal, and they don't want to go to public because it's very not very hygienic. So can you give? Yes, you can give the vaccination at your place, and you should consider that intradermal as the initial priming dose, and you should continue the vaccine, whatever the doses are required. So if similarly, if they have taken intramuscular at your place, and if they want to take ID at public place, they can definitely go. You can always interchange the vaccine brand from chick embryo to Virocell. There is no There is no like you should not take it. If the immunoglobulin was not given in the first dose of post-exposure, till what time? So I've already said that till 7 days you can give immunoglobulin. But if the immunoglobulin is not given in, the child has received post-exposure prophylaxis, then after 7 days you should not give immunoglobulin because it's a waste of money. But if the child has not been taken vaccination and if the child comes, then you should, along with the vaccine, you should always give rabies immunoglobulin. If the post-exposure prophylaxis is delayed, how long you can still start? Weeks, months, years? Yeah, you can use till 1 year of age. After 1 year, there is no point in starting because rabies immunoglobulin can start developing. Virus can remain till 1 year maximum. After that, it has not been studied or proved. If a subsequent dose of post-exposure prophylaxis is missed, how do you proceed? So if the child has taken one dose and if the child has not taken second and the third dose, then you should complete your at least 2 or 3 doses in the initial 7 to 10 days of time to achieve the antibodies titer as early as possible. And then, so if the child has taken 0 dose and child has come on 5th day, then child has missed 3rd and the 7th dose. So on 5th day, you should give 3rd dose. On 7th day itself, that means after 2 days, again, you should give your 7th dose. And then 14th and 20th, accordingly, you can give, you can delay the vaccine. But you should try and give your vaccination initial first 3 doses as early as possible to achieve the antibody titers as early as possible. If the child has taken first dose of intradermal at public health and now wants to continue India, so I've already said that child can anything ID or intramuscular can be switched over. There is no problem about it. So I think I've covered almost most of the part. I may be a little bit fast. I may be a little bit, but I think I've tried to cover. If anybody wants to ask something, definitely I'm ready to do that. Thank you.
Thank you, Shailesh. Thank you.
Thank you, sir, for the excellent presentation on rabies vaccination. I hope your lecture was clear, so there's no questions. And
Very
It
nice.
was very good. We are all rabid now.
Ma'am just wanted to add little. I remember one 6-month-old had come to me, cat scratch on the nose, and that time I was so very confused. And sir had guided me properly. Eventually, we offered the monoclonal antibody. They gave negative consent, but like sir said, it's very important to offer medico-legally also and for the patient also.
you should always document if they don't want to take the antibodies or immunoglobulin, because otherwise, if later, because rabies is not going to manifest in within 1 month, it might present later also. In that time, people will come and sue you. So it is always better to document. Yeah.
Shailesh, what about safety in pregnant mothers?
It is safe, very safe. Immunoglobulin as well as vaccine, both are safe.
Dr. Ajay Kedia is there, so if Archana doesn't mind, can
Yes,
you
yes.
go ahead?
Yes, Anjali, all the time.
Yeah.
So our next speaker is Dr. Anjali Kokarna. Madam is a practicing pediatrician and neonatologist
Everybody here knows, yeah.
in Vasai. Okay, so welcome, madam. And your talk is on interesting skin conditions. And for this talk, we have an expert with us, Dr. Ajay Kedia, who is a dermatologist. So welcome, sir, to this webinar.
Thank you and hello, doctors. I'm glad to be part of.
Dr. Ajay Kedia has been practicing dermatology for over 25 years, and he's been visiting Vasai, and he's our go-to person for any skin condition. So I'd like to directly go to this. I don't know whether this is going to become, yeah.
Yeah.
So the weather is just right for staphylococcal scalded skin syndrome. And a father of a 4.5-year-old child sent me pictures, which I will be showing you subsequently. 4 days earlier, the child had high fever and stomach pain. The stomach pain was so bad, and he had it localized on the right iliac fossa. In fact, for some time, I thought it was even appendicitis. I got ultrasound done, and I gave some non-specific treatment initially, and then I gave cefixime. And then I forgot all about it. For 4 days, the child was all right. But 4 days later, the child's father said that this is, something that is coming up on his face next to his nose. This is on the side of his chest, and this is on his face, and this is on his prepuce. So I was a little confused on the first day. So he said, no, this is because of drug rash. So I said, it's unlikely because I've not seen a drug rash like this. And I said, you come next day to the OPD. And fortunately, Dr. Ajay also was there, and he had a look at him. And at the first look, he said, this is impetigo. And he started on azithromycin. And the parents went home and they spoke to the whole colony and to their relatives. I don't know how people show their whole family, and everybody said it's chicken pox, it seems, and they didn't start medicine. And then after this was next day, I didn't even know they have not started. The day they came, we started azithromycin, but next day he's saying, see, look at this, what has happened. This has come on his finger, and there is a blister like thing. Now, this was the first blister that came up on day 2 of what was there. And I said, yeah, he's under treatment and he'll do well. Even then, he didn't tell me that he's not under treatment. And day 4, not on treatment, this was the look. He's saying, look what is happening. And I was really wondering, I said, is this going into something like Steven Johnson's? But when he came the first time also, there were no mucosal involvement at all. And by now, there was not much fever. The fever was mild. Initially, the fever when he had stomach pain was high. And this was on day 4 of the infection. And then he started getting, even around cracking and drying around his mouth, nose. See the skin on the neck as well. These are blisters on his back. And because this was spreading quite rapidly, and what was unexpected was I thought skin lesions are localized, and why is it coming over here? And we only know of mucocutaneous involvement when it is either Kawasaki or some connective tissue disease, or we think of Steven Johnson's. And then they told me that they have not started treatment at all because everyone thought it was chickenpox, and they came again and they showed Dr. Ajay Kedia. And by this time, see what has happened. The whole thing was blistering. So if you can see the skin on his left hand inside, see it's so loose, and there were blisters all over. And this was on his back as well. See his back, there was anorectal involvement. There were some blisters here. That's what his father is showing. And now again, luckily for me, Dr. Ajay Kedia was there again. And this was about 5 days later. And Dr. Ajay, would you like to say something? And he told me, Anjali, this is nothing but staphylococcal scalded skin syndrome. I have seen staphylococcal scalded skin syndrome, but it was only in neonates, and I never thought a 5-year-old would get that. So I'd like Dr. Ajay to explain.
So, thank you, Dr. Anjali. So, in neonates and infantile, staphylococcal scalded skin syndrome is a little dangerous because of dehydration. And it can be a little mortality is high. But as the child grows up, it is more of morbidity. Usually, these children recover completely because the staph infection is local, and the toxins, which is exfoliative toxin A and B, they spread hematogenously. So within maybe 3 or 4 days, if treatment is not taken on time, they can go into exfoliation of skin. And this exfoliation is intraepidermal, meaning it is very superficial. So, like we have different signs called Nikolsky sign. There is skin tenderness. So this, I mean, just touching the skin, it can blister. It is so superficial, and the child complains of tenderness in the skin. So we need to just rule out that it is not a drug reaction. So this child, because he was given medicines for stomach ache and he had bullae, we also had drug reaction in mind. So we did not jump to coamoxiclav as first treatment. Otherwise, that would be great. So the moment he started getting this exfoliation in the skin, it was very clear that this is staphylococcal scalded. And you give antibiotics, the child recovers. If you feel there is dehydration, you need to admit and give IV fluids. Otherwise, best is just start early, give antibiotics, and the child recovers completely. Why children are more prone is because their renal conditions to remove the exfoliative toxins are not very well developed compared to adults. In adults also, those on chemotherapy or those who are really immunosuppressed, who have renal problems, they also may get staphylococcal scalded. So, I mean, this was very classical, and luckily the child was always active and alert and did well. The moment they understood and they took the antibiotic, the child did well.
Yeah. So that is what happened, and this was, still after starting coamoxiclav, the chest was exfoliating, and then he started recovering slowly. The lesions were desquamating. There were no lesions coming up. This was what was happening. This was what was happening. They were like, the whole body was exfoliating. This was what was happening, and the lesion at the back had cleared. And as soon as we started Comoxiclav, what the father said was that I'm happy his appetite has improved. And that's when I knew that he's responding. And they could not do blood tests because skin pain. Now, this is the first time we've heard of pain everywhere, and even they show it on the body. Of course, the skin is there. But the father said that we cannot even touch him. His skin is painful. And this was the first time I realized that the skin can also pain so much, although we know that skin is the most, innervated organ of the body. And they had not done blood tests because they could not touch him. They said, anywhere we touch, it's blistering. So they were afraid to do a blood test. Otherwise, I would have, at least something to know that this is infective or not. And but he developed some new lesions over the hands. So, Dr. Ajay, please let me know what happened is that the blisters and everything was going, but something like urticaria was developing. So this was while he was on coamoxiclav.
So no, this was a chance event, nothing related with our treatment as well as to staphylococcal scalded. They had come to me once that there is erythema on the lesions.
Yeah.
But it was because the skin was exposed.
Yeah.
And usually this exfoliative toxins are in the blood. So even if you think about doing a blood culture or anything, you won't get anything because this is very much proved that the organism is local, the exfoliative toxin is
systemic.
Systemically. Secondly, the exfoliation of skin is so bad that sheets of skin can come out on the soles. And usually the exfoliation is first on upper limbs and body. And 7 days or 10 days later, the whole exfoliation on the lower limbs and soles can happen. The only thing in such cases we need to differentiate is from drug reactions. And what drug reaction can cause this kind of exfoliation is toxic epidermal necrolysis. So Steven Johnson's is ruled out because you can see in that. So now how to differentiate from drug reaction? In this, there will be less of mucosal involvement because here there are different adhesion molecules, keratinocyte adhesion molecules called desmoglein 1 and 3. So this is mainly affecting the desmoglein 1. That's why the separation, the exfoliation is on skin. If it would involve mucosal, then desmoglein 3 is also affected. So suppose you are in doubt. So one, skin tenderness is a important thing. Two, a local staphylococcal infection. So you should check the ears, eyes, nose, genitals. A local staphylococcal infection is the nidus. And three, if you're in doubt, you can get antibodies to desmoglein 1 and 3 done. So if 3 is positive, yeah, then you have to think about more of drug reactions. So if 3 is not there, which is mucosal dependent, then such lesions you should think about staphylococcal skull death.
Endotoxin. Thank you. And so this is what was worried. And then we got a blood test finally, but that was on day 12 of the illness. And so it had taken so long, huh? It's not that the recovery was fast or within 3 or 5 days or 7 days or 10 days. It took 12 days and still the skin was coming out. And the hemoglobin was normal, WBC was 8,500, the platelets was 3,300, CRP was negative, and all other systemic tests were negative, normal. So that was very, very reassuring. He completed the course for how many days did we give him? 7 days or 10 days, Ajay?
10 days. But the best part is he again did not come for a follow-up. So this is India.
Yeah, but it was 12 days and there were new lesions daily on those 12 days. And this was on day 16. Ajay, he did send me a photograph on day 16 saying that now he's finally all right and his whole skin, he had, had exfoliated. And this is what was finally there. So this, friends, was staphylococcal scalded skin syndrome. This is the first time I've seen it in a 5-year-old. I have seen several newborns and younger infants getting it, but this is the first time I saw it. And like Dr. Ajay said, it's because of an endotoxin and not because of the Staphylococcus aureus itself. And just a few days ago, Dr. Ajay, I saw one more case. Now, if you see, this child also has it like this. And although there is no, generalized bullous formation, this is very localized. And I gave him only Novamox, and I gave him only amoxicillin, and this was his recovery in a few days. So of course, Ajay will tell us more. So I would call this bullous impetigo and not staphylococcal. Of course, the organism is the same. It is staphylococcus, and both are because of the endotoxin, but one is localized and one is systemic spread of the endotoxin. And here it is only localized to one part of the body. Ajay, you would like to say something of the difference between these two cases?
No, ma'am. As staphylococcal scalded is because that endotoxin is moving hematogenously. This is a skin infection, so nothing is going hematogenous. That's why the split is because again bullous impetigo, meaning the staphylococcal is creating the honey-colored fluid, which is infective, and that is why it is separating the epidermis at a local level.
Okay. So bullous impetigo is local, whereas staphylococcal scalded skin is systemic. So that was, but this is the season for such skin infections in our country. And while I was looking for, literature on staphylococcals, what he has said about desmoglein 1. And the antibiotic treatment, I was surprised to see that penicillin resistant, nafcillin, oxacillin, cephalosporin, vancomycin. But fortunately for us, our patient responded just to co-amoxiclav. So we were very lucky and we used only that. And what gave me courage in the second patient was that it responded, such severe infection responded to co-amoxiclav. This simple infection would respond to just plain amoxicillin, and I'm sure even use
you feel then is also a very good choice. Mostly we don't, and but most of the times, because children usually respond to these drugs, it's adults and hospital patients developing these MRSA, Staph aureus infections, children usually do very well with coamoxiclav.
Yeah. So since it was a community infection, it responded very well to amoxicillin, not a hospitalized and an immunocompromised patient. So that's it. And of course, there are potential complications, like he said, of dehydration, electrolyte imbalance, sepsis, and death. And recurrences are rare. That's all I wanted to say for today. And I know that this is a common thing, but I had not seen SSS for a very long time. That's all. Thank you so much, Ajay, for being available to talk with us.
No, ma'am, for
Yeah.
it.
Yeah.
Listen,
Yes. Sir, बोला ना.
आमच्याकडे एक चिकन पॉक्सचा मुलगा आला विथ सेकंडरी स्ट्रेप्टोकॉकल इन्फेक्शन विथ थिन पस, पण डोळे सुजलेले, दिसत नाही, and they came in crisis, and we put him on benzyl penicillin and he is all right. So his eyes were bad. He was referred to Mumbai for his eye condition. The vision is not involved. He has got infection everywhere, including the eyelids. So they were worried. But it was thin pus, so we knew it is streptococcal. So we put him on IV benzyl penicillin and he's okay. So I wanted to tell you two things. One, plenty of chicken pox around. So we should tell our children two things. One, if you afford to take chickenpox vaccine, if you don't afford, have a chickenpox party. Means globally they would send all the children to play with a child having chickenpox, so that everybody got it at the youngest possible age. The younger the age, less is the suffering. So they were called as chickenpox parties. Similar parties were made for mumps. So those who afford the vaccine, they should take the vaccine, or they should, his second choice. And third, benzyl penicillin is queen of antibiotics. It works in 4 hours well, and it works most of the times. And it has worked with every time we have used it for last 2 decades. And it is available, and thanks to Anjali that we get benzyl penicillin. झालं माझं, thank you. अंजली तुझा आवाज गेला.
हा, मी आता माझा आवाज नाहीतरी गेलेला.
There is one question in the chat box. How do you differentiate between SSS and toxic epidermal necrosis, TEN?
That's a question for Dr. Ajay.
Sir, SSS will start with target lesions. So that's both are drug reactions. Though many times toxic epidermal necrolysis, you don't get a drug history. And toxic epidermal necrolysis will be huge blisters without target lesions, the whole skin separating as if it's if you see after a few days, it could look like a burns case also. So toxic epidermal necrolysis is more fatal. You need more systemic management where you have to maintain fluid electrolyte balance, temperature, meaning everything like a burns. Then he can go into septic shock. He can go into infection because of all open wounds. So Steven-Johnson's is usually you'll have mucosal involvement, you'll have target lesions. It won't be so drastic to start with like toxic epidermal necrolysis. So these are the points.
Thank you, sir. Yeah.
Thank you. Thank you, Dr. Kedia.
So,
डॉक्टर केडिया,
हाँ सर.
एक पब्लिक रिक्वेस्ट. मी एकदम गाढव आहे, मला स्किन कळत नाही. कारण की ते काय, दे डोंट कॉल स्पेड. सायंटिस्टनी काय केलं, दे यूज रेअर अँड रेअर वर्ड्स. आम्हाला इम्पिटिगो कळत नाही, आम्हाला स्कॅन्डर्ड स्किन नाही कळत, म्हणजे काय ते इंग्रजीने वाटोळ करून टाकलाय. हुशारी काय होईल माहितीये का, की सिंपल भाषेमध्ये स्किन सांगणं, डेंटिस्ट्री सांगणं. आणि आमच्या 150 कोटी भारतीयामध्ये कोणाला वेळच नाही करायला आहे. आता तुम्ही सिनियर आहेत आणि छोट्या माणसाला सांगून फायदा नाही. तुम्हाला जमलं तर सोप्या भाषेमध्ये स्किन सांगा ना. म्हणजे स्किन तुम्ही सिंपल इंग्लिशमध्ये, देर आर 2 विकिपीडियाज, एक इंग्लिश विकिपीडिया आणि एक सिंपल इंग्लिश विकिपीडिया. तसं एक सिंपल इंग्लिश स्किनचं पुस्तक करायला पाहिजे, किंवा आर्टिकल तरी करायला पाहिजे, किंवा ऍटलिस्ट आम्हाला तरी शिकवायला पाहिजे पीडिया आमच्या या नेक्स्ट वेडनेसडेला. तर फार मोठी मेहरबानी होऊन जाईल. सगळं वाटोळं इंग्लिशने केलंय. इम्पेडिगोच कळत नाही, मग कसलं हाऊ कॅन वी ट्रीट राईट? आम्हाला इम्पेडिगो नाही कळत आणि आम्हाला कळत नाही, हे पण आम्हाला कळत नाही. आम्ही पोपट सारखं ते पाठ करून टाकतात. आय विल टेल यू वन एक्झाम्पल फॉर एव्हरीबडी सेक. वाडे हॉस्पिटलला गेलं एव्हरी फ्रायडे all pediatricians met at different medical colleges. So we went on every Friday. So I'm telling you something 25 years earlier. So on one Friday, one case was presented, so and so Niagara. I was a young boy then. I just stood up and said, what is Niagara? So the one who presented, he said, I do not know. Yeah, my boss will tell. The boss said, I do not know. Then I asked, does anybody in the hall know what is Niagara? So nobody knew that. Everybody was a parrot. So I just came home and saw the Niagara means black and Niagara means very black. Means he had a skin patch which was black since birth. That's all. So असा गाढवपणा एंटायर मेडिसिन मध्ये. आमच्यावर दया करा आणि थोडा उजेड पाडा. आम्ही सगळे अंधारामध्ये आहे. मला स्किनचं स्पेलिंग CKN हे पण माहित नाही. आणि हे कोणाच्या कानावर जात नाही, कारण आम्ही सगळं मोठं आहे. डोकं आणि मेंदू बंद करून, कान बंद करून आमची प्रॅक्टिस चालते. त्यामुळे भारत छान चाललाय. सो अशी नम्र विनंती, झालं नाही तर काय हरकत नाही.
Sir, let's see how it will try.
हा, केल्याने होणार. मराठी करा, हिंदी करा, मारवाडी करा. किती दिवस रोमन मध्ये? आम्ही रोमन मध्ये जगणार, रोमन मध्येच मरणार. आमचा देश असाच राहणार. अशी विनंती, नाही झालं तर चालेल. तुम्ही घरी गुजराती बोलता की मारवाडी बोलतात?
Hindi.
बरं. भोजपुरी, मैथिली, मगी होती, कोणती हिंदी?
Simple Hindi.
सिंपल हिंदी. बरं, ओके. थँक्यू.
Much
थँक्यू.
to-
Gurudev Bhava. We learned good, nice things. Thank you.
Thank you, sir.
Thank you, Ajay.
Thank you, ma'am.
Yes, thank you, Ajay sir, and thank you, Gokarna madam, for the excellent case. And
नेक्स्ट टाइम करायचं का पोस्टपोन करायचं का? 5:15 झाले.
Sure. This is a good idea.
अर्चना, किती वेळाचा आहे?
10 स्लाइड्स आहे फक्त.
दाखवूनच टाका.
दाखवून देऊ. बरं.
हो.
So our next speaker is Dr. Archana Joshi. Madam is a practicing pediatrician and neonatologist in Virar, and the senior most pediatrician. She is an ex-president of IAP Palghar branch and currently president of Virar Medical Association. Madam and sir has together make the 6-month maternity leave. She is a recipient of...
आधीच उशीर झाला, कुठे वेळ घालवते.
Okay. Welcome, Joshi madam, for your talk on cyber Suraksha.
स्लाइड शेअर करते.
Yes,
स्लाइड सेकंड वाली पाहिजे. फर्स्ट कशी आली? मग स्लाइड शेअर कर. स्लाइड दिसते का?
नाही मॅडम.
नाही दिसत आहे. स्लाइड शेअर नाही. जस्ट अ मिनिट. टेकिंग सम टेक्निकल हेल्प येते. फर्स्ट स्लाइड पाहिजे. फर्स्ट स्लाइड शेअर. स्लाइड शेअर.
Thank you, Vaibhavi, for moderating this session. And thank you, everyone. Dr. Jagdish, you have anything to say?
फर्स्ट पाहिजे. Starts from
Anjali, only for that antibiotic choice for staphylococcus. Okay, whatever you said is the first generation cephalosporins and only amoxicillin would work only for cons, that is MSSA.
Yes.
It won't work for MRSA.
Yes.
Second thing, penicillin would work only for streptococcus and not for staphylococcus any time. That is all I wanted to say.
Thank you so much, Jagdish, for that valuable input. Thank you.
मॅडम स्लाइड आता दिसत होत्या.
दिसत होते ना, आता परत गायब झाले. जस्ट गेटिंग देम बॅक.
Yes.
सायबर बुलिंग.
Jagdish, next time, can we have some students from some of your students present cases and attend the session?
Yeah. होपफुली एक्झाम नसेल त्यावेळेला तर मोस्टली
चालेल.
around that time there are exams,
I
PG
know.
prelims are going on.
Okay, okay. Yeah, sure.
Our next monthly CMV will be on 24th of June, last Wednesday.
Online,
Yeah, online.
work from home.
Yeah.
Vaibhavi,
Great.
Vaibhavi,
Ah,
Vaibhavi,
Yes,
that
madam.
day
yes.
we
Yes,
have
yes.
a general body meeting of Virar Medical Association that day. So may not be
Okay,
able to.
we'll change the date. Yes, madam.
Thank you so much. So today we are going to talk on cyber self-defense. I'm thankful to Dr. Jayashree Deshpande who has shared this slide. This topic is of great concern to her and she has shared those slides. I will just be presenting. So all of us use mobiles and we have to stay safe with these mobiles. We have to stay smart, we have to stay safe, we have to stay strong, and we have to see that our old aged parents in the house and our teenagers are also safe. Because safety is not by choice, it is by choice, not by chance. Slide is not moving now. In second. So why cyber safety matters? Because all of us use it. There's not single person who doesn't you have a mobile phone. So today's world is online and offline. So one click can change your life. Cyber crimes are increasing in teens. I have two patients who has bought a car on Flipkart. He's 1.5 years old child. And other child has spent some 50,000 of his mother's money just on the mobile. And you can't do anything. So it's better not to keep the mobiles locked and don't give it to children. So cyber crimes are increasing in teens. There's hacking, bullying, scams, and we have to tell our children that not everyone online is your friend. So this slide shows that there are hackers. If you don't have a proper DigiLock, and you have to be very careful. So what are the types of cyber threats? There's cyber bullying. Somebody's a loser, you lose a friend, somebody's hurting you, somebody's not appreciating your post you have put, there's hurting someone through messages, comments, or posts. There are fake profiles. People create fake account to pretend to be someone else. And there are gaming traps. They'll tell you we'll offer something, fake games, and that steal your data and money. They tell children that they'll get some free money or free gems. And for want of that, the children play these games and get caught into the trap. So we need to spot these threats early and stay one step ahead. We have to also see that there is no online stalking. There are some people who keep watching all the time. They keep tracking on what you're doing, what you're posting, what you're doing. There are phishing scams, there are trick messages or emails that steal your personal information like password or bank details. I myself have fallen trap to this scam and have lost some 38,000 rupees. There was a message saying that your electricity will be cut. It was in rainy season, the hospital was full, there were patients on ventilators, and I was worried. So they told that your electricity will be cut, you pay this money. Click on this and pay the money. So luckily for me, my accountant did it from her mobile. So she had some 38,000 rupees and that got lost, but she didn't do it from my mobile. That was great. So then we did a lot of up and down. We approached the police and cyber people and all, but we could not get that money back. So this has happened. And there are scams like this telling, I'm your father's friend and your father gave me some 20,000 rupees. So I'm going to send you this money and give me your mobile number and also. So things do happen with us also. So we need to stay alert and stay safe. So our houses are protected, but we need to protect our mobile with a strong password and strong protection. This we have done. So we need to have a strong password. Like for a house, we have two doors, strong doors, we have locks. So in the same way, we need to have a strong password. We can't write Archana at 123. So they will know my name is Archana and 123 is a common. So this is a weak password. It's too short. It's easy to guess. It uses common words or numbers. It can be hacked easily. So never share your password with anyone and change your password regularly. Use two-factor authentication if possible. Have a strong password. Have long 12 characters like this password, like PR, exclamation mark, at the rate V31 dash 2024 hash safe and a correct mark. So this is a very long and nobody can remember it. If we also have to use it, we need to write it somewhere. There should be mix of letters, numbers and symbols and exclamation marks, and it should be unique for each account, and it should be hard to guess and hard to hack. So use a two-factor authentication and don't write your password where others can see. So think of a password like your house key. Now, would you give your house key to everyone? No. So you need to be very careful. Safety, social media safety. Share smart, stay safe. So keep your accounts private. Set your profile to private. Don't share your personal information. Don't share your location. The children like to say, keep telling their friends, I have gone to Manali, I'm on a holiday, I'm with my parents, I'm with my grandparents. Don't tell your address. Don't tell your daily routine. Think before you post. This we should tell our teenagers. Don't post personal photos or videos publicly. They can be misused. Accept requests wisely. If a friend requests you, take requests only from the people you know, not from unknown people. Check your privacy settings. Review and update your privacy settings regularly. Remember, once it's online, it can stay online forever. So your safety is in your own hands. So don't share your location, your school, your where you're staying, where you're going for a holiday, your phone number, and your personal photos with everyone. Because not everyone online is who they say they are. They are not real people. So be smart, be safe, and be strong. Sixth slide. It is six. Beware of strangers online. Strangers may pretend. They may lie about who they are. Don't trust too quickly. They may be friendly to gain your trust. Don't share personal information. Never share your address, school, phone number, and photos. Don't meet them in real life. Never meet someone who only know online. You may get fooled. Tell a trusted adult. You can tell your parents, your teachers, and tell your teacher also if somebody makes you feel uncomfortable. So the people online may say, I am 16 too. Let's be friends. They may make friends with your daughters or sons, or they may like your photos and say, cool photos. And we like the same games. I live next to you. Can we meet? Can we have a cup of tea? So they try to make friends, and teenagers may get fooled and try to meet these people. So if something feels wrong, it is probably is. So we must talk to a trusted adult. All of us parents should be friends with our children, be friendly with them. As in Sanskrit, it is said, Prapate Shodashe Varshi Putra Mitra Samacharit. So we should be friends with our children and we should be there to help them whenever they need. Cyberbullying, speak up, be kind online. Your words have power. Now, what is cyberbullying? Using the internet, social media, or phones to hurt, embarrass, or threaten someone on person. You're so ugly, nobody likes you, trying to uh, bully someone. So, what you can do is you can be kind and respectful online. Treat others the way you want to be treated. We need to support our friends. If we see someone being bullied, stand up for them and get help. Spread positivity, encourage, include, and be a friend to others. So, we online, all our friends, we should help our friends who are being bullied online. We should be kind, we should be respectful, and we should be a digital hero. Kind words can be short and easy to speak, but their echoes are truly endless. So we should see that our friends are not hurt. What if somebody does this to you? What to do if this happens to you? Don't respond. Don't reply to hurtful messages. Keep quiet. Ignore. Block that person. block and report the person who is bullying you. Save the evidence, take the screenshot, and keep the proof of bullying for the police. And tell a trusted adult. Talk to your parents, your teachers, or a trusted adult right away. And parents must tell children, you are not alone, my child. We are with you and we are here for you. So speak up and reach out and stop cyberbullying. Safe online behavior. We are all online most of the time, so we should have a safe online behavior. Keep your information private. Don't share personal information like your address, phone number, or school online. Think before you click. Be careful with links, downloads, and attachment. I had I had clicked a link and I fell into a trap of 38,000. Balance the screen time. Spend time online, but don't forget real life. Take breaks and stay active. Download safely. Download apps, games, and files only from trusted sources. Keep accounts secure. Use strong passwords like the one I told you, 12-character password, and enable two-factor authentication whenever possible. Be respectful online. If the other person is also harsh, we need to be respectful because we are dignified people. Treat others the way you want to be treated. So be smart, be safe, be kind. Every click counts, so choose safe. Remember, protect your privacy, it's your right. Think, check, then click. Be kind, be helpful, build a better online world. Stay safe today so you can enjoy a better tomorrow. Together, we can stay safe online. So be with friends who are good and they are good digital citizens. Make smart choices. So emergency actions, what we can do? What if something happens to you? Slide number 9. If something happens online and it makes you feel scared, uncomfortable, or unsafe, don't panic. Take action right away. Tell a trusted adult that you are not alone. Take help from someone. When to take action? If you see something scary, inappropriate, or illegal, or if someone is bullying, threatening, or harassing you, or if a stranger asks for personal information or makes you feel uncomfortable, if you are asked to download something suspicious, or if you are asked for money or any kind of payment, so you better ask and then only make payments. Your important contacts are, my dear friends, your parents, your guardians, your friends. We need to tell them immediately, talk to them. Your teachers, for children, we have teachers, school counselors. Ask for help at school. Then there are cybercrime helplines in India. 1930 is the cybercrime government of India number. You can note this down and use it whenever you need it. What to do if something happens? It's simple 5 steps. Tell a trusted adult, parent, or teacher, or your friend. You can have a friend at our age. We can have friends who are very trusted and we can talk to them. Save the evidence. Take a screenshot, copy the message, block the person. Do not respond, just neglect. And report the person or content on the platform. Stay safe, stay calm, and follow the advice of trusted adults. You are important, you are safe, and we are there to help. This is what the parents or your friends will tell you. Because it's not your fault. Asking for help is smart and strong choice. This is not your fault that you have fallen into a trap. This can happen with anyone. So, final message, my dear friends, to end. Stay safe, stay smart, stay kind. The internet is an amazing place. Use it safely and responsibility. We have all used this digital platform for learning during COVID days, and it has made all of us wiser. Today also, we are using this platform to learn. We have heard so many good cases today. And the key reminders are protect your privacy, keep your personal information private, think before you click, be careful with links, downloads, and messages, be kind online, treat others with respect. Your words matter. Beware of strangers. Not everyone online is who they say they are. Speak up. Talk to a trusted adult or a friend if something feels wrong. use strong security, use strong passwords, 12 character passwords, and keep your accounts safe. And be a positive digital citizen. Use technology for learning and growth, like all of us are doing today. Create, inspire, and encourage others. Respect everyone's privacy and feelings. Help to make this internet a better place for all. The best way to enjoy the digital world is to stay alert, stay kind, and stay safe. Remember, it's not just about staying safe online, it is also about being smart and kind online. So, together, we can build a kinder digital world. So, you can make a difference, my dear friends. So, stay safe, stay smart, and stay kind. Thank you, my dear friends. Thank you,
Excellent,
Anjali.
Archana. Excellent, Archana.
Chota
Thank you.
chota.
Thank you, madam. This lecture is very apt to the current situation where the youngsters keep on clicking any link, whatever they see, and then fall prey to it. So, thank you, madam. Yeah.
Thank you. Thank you, Vaibhavi, for a wonderful moderation.
There's a linking road on our laptop.
Link Road.
Link road.
Very
So we
nice.
had a nice case discussion today, and I thought it would be late. It is
On time.
36. Yeah, just 6
Mस्त.
minutes past. झाला.
छान झालं.
Just take additional information सांगतो.
हा.
19 Archana 1930 is only for financial cyber crimes.
अच्छा.
fraud. But for other cyber crimes where FIR gets lodged is 1945.
1945. Okay.
Yeah.
Okay, so we should remember 1945
30
more.
and 1945.
हाँ.
Okay. Yes.
Okay.
Thank you. Thank you, Jagdish, for this
Thank you,
additional.
Jagdish. Jagdish, please present something next time. तुम्ही केवढे patient बघता.
Okay,
Oh,
madam.
सांगतो.
So we come to the conclusion of meeting. I'll stop the recording now. Yeah.
Yeah.
Well done.
Vaibhavi.